Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Thursday, January 18th, 2024. The time is 9:32 a.m. Today we are here to hear public testimony on the performance of the district's Department of Health, or DC Health, and FY 2023 and FY 2024 to date. This is a hybrid hearing. We're in room 500 of the Wilson Building, but we'll have public witnesses testifying both in person and virtually on the Zoom platform. DC Health promotes health, wellness, and equity in the district and protects the safety of residents, visitors, and those doing business in the nation's capital. With almost 750 FTEs, DC Health is organized into 7 administrations and offices: Agency Management, Community Health Administration, Health Emergency Preparedness Response Administration, the Center for Policy Planning and Evaluation, the HIV, Hepatitis, STDs, TB Administration, Health Regulation and Licensing Administration, and the Office of Health Equity. The committee sent written pre-hearing questions to DC Health, and we will reference those throughout. We will reference those materials today and next week. If anyone would like to see those materials, they can be found online on the DC Council website. If you go to dccouncil.gov/hearings, and if you click on this particular hearing, you'll see the documents there. I don't see any of my colleagues who are here for opening statement, so we're going to go ahead and get started. And of course, as anyone joins us, we'll let them speak. I want to review the testimony guidelines for public witnesses. Given the large number of public witnesses we have today, all witnesses will have 3 minutes to testify. It's not because we don't want to hear what you have to say, but it is because we want to allow time to hear what everybody has to say. We will give you a little nudge when your time has expired. To make sure we get to everyone, your name will only be called once where it appears on the list. So we might have a situation. Some of you have seen the witness list. If you are here in person, but your name is on virtual, you need to let us know because we otherwise wouldn't call you. And so vice versa. Well, if we call someone who is on the in-person and they're virtual, we'll deal with that as it comes. But for those who are sitting here, just make sure that we get to you. So for the in-person pieces, I only have 4 chairs, so we're going to be doing panels of 4. When we go to virtual, we'll switch to our panels of 7 or 8, depending on how we're feeling at the time. All right. For anyone who was not able to testify or speak today, we'll be accepting public witness testimony until February 1st at 5 p.m. Again, you could submit it all online on the DC Council website hearing management system. All right. I will call the first panel of witnesses. Okay. Deborah Thomas, Leah Kaslas, Katie Lee, and Jacqueline Bowens. All right. Ms. Thomas, when you're ready, you just hit the button in front of you to turn on your microphone. There you go.
Good morning. My name is Deborah Thomas. I'm a nurse consultant employed by the District of Columbia Nurses Association, and we represent registered nurses and licensed practical nurses in children's school services. On November 22nd, 2023, we sent a letter to the DC Board of Nursing seeking assistance and looking at the cluster model, which was unceremoniously started in September 2023. This letter outlined growing concerns that CSS administration had been allowed to circumvent the DC Nurse Practice Act and HORA, creating a model that would allow unlicensed personnel to have greater responsibility in the health suites and require the professional nursing staff to provide remote delegatory support to 3 to 4 schools in the cluster model. This leaves most schools without professional nursing support, delivery of services being inappropriately delegated to unlicensed personnel who have not been trained as set forth by the DC Board of Nursing Trained Employee Program. The model violates the Public School Amendment Act of 2017. It also violates the DC Nurse Practice Act, and it also violates DC Law 17707, SATA, which in part states that allied health professionals perform selected tasks, including medication administration, under the supervision of licensed practical nurses and registered nurses. They are violations of the Americans with Disabilities Act as well, in providing care to children with chronic illnesses such as diabetes and asthma. This ignorance points to the lack of knowledge of nurse practice in this setting and the legal liability associated with that lack. Let the record show that the City Council sanctioned this model in June 2023 without coming to the DC Board of Nursing, looking at whether it would affect nurse practice and the DC Nurses Association. We are the experts in this area. Now, this report, I have a report that was sent by a school nurse on January 12, 2024, and it just illustrates the point exactly. I don't need to say any more. One RN cannot properly do case management and make sure plans are implemented for that number of students. In most of the care plans I and other DCSPS nurses do, we have never seen the student because there is not enough time to go to every school and assess the students. I am not at any one school long enough to follow up. Techs cannot follow up on major diagnoses. One RN cannot oversee a tech with no license working remotely. One RN cannot respond to emergencies at various locations while already caring for students at your assigned location. My tech wants more time with me. They thought they were working with the nurse, not replacing them. The telehealth system cannot substitute for nurse assessment. Many of my colleagues left for Maryland schools where the administration understands the role of the nurse and the laws that govern healthcare. In conclusion, this is a request that the DC City Council Committee on Health intervene on this issue before a child suffers from our lack of legal accountability. We have an opportunity to create a model of change. A nurse in every school is just the beginning. We can attract and create a pool of trained personnel. The city has the resources, educational systems to do just that. But CSS must at least be held to standards of appropriate care delivery as outlined by DC law.
Ms. Thomas, if you could just wrap up a little, about a minute over your time already.
All righty. Thank you.
Thank you so much. All right, Leah.
Good morning, Chairperson Henderson and Committee on Health staff. My name is Leah Kaslas. I'm a policy attorney at Children's Law Center and a resident of the district. I'm testifying today on behalf of Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys toward a future where every child can grow up with a strong foundation of family, health, and education and live in a world free from poverty, trauma, racism, and other forms of oppression. Thank you for the opportunity to testify today regarding the performance of DC Health over the past year. My oral testimony will discuss the DC Health funded home visiting programs. My written testimony goes into greater detail regarding the following topics: DC Health's continued implementation of healthy steps and opportunities for growth through Medicaid reimbursement, DC Health's role in supporting perinatal health in the district, as highlighted in the newly released Perinatal Mental Health Task Force report, underscores the need for greater investment in DC's healthcare workforce, including community health workers, and discusses DC Health's needed engagement with the relaunched 211 warm line. This committee had two recent opportunities to hear about the immense value of home visiting programs. There, however, continues to be confusion around this investment. Last April, DC Health stated that although the agency was decreasing the award amounts to certain grantees, there would be no reduction to overall home visiting funding in the FY 2023 budget as compared with the previous year. Later, however, DC Health reported there being an overall reduction in funding for home visiting programs in FY 23. Changing and confusing budget lines for programs are destabilizing and cause programs to pause hiring, increase caseloads for current home visitors, and ultimately lower the number of families they are able to serve. Further, this confusion made it hard for the council, the agency, and advocates to know how much funding was needed for home visiting in the FY 2024 budget. Additionally, grantees were told by DC Health that cuts to their programs were due to there being vacant positions, which continue to persist due to low wages and lack of investment in the home visiting workforce. Cutting grants instead of working with programs to fill vacant positions exacerbates workforce issues. We urge this committee to ask DC Health to partner with programs to address ongoing staffing issues with home visiting programs rather than simply cut funding. Additionally, DC Health must increase transparency and communication regarding the home visiting budgets to allow programs to stabilize and properly plan for hiring, as well as the number of families served. We were glad to see that this has begun in their performance oversight responses. We need clear understanding of DC Health funding for home visiting ahead of the passage of the DC Home Visiting Medicaid Reimbursement Act of 2023. Thank you for the opportunity to testify today. I welcome any questions the committee may have.
Thank you. Ms. Lee?
Good morning, Chair Henderson and council staff. Thank you for the opportunity to testify before you today. I'm a resident of Ward 8 and I'm a member of the Volunteers for HRA Reform. I was a volunteer for 7 years with the Humane Rescue Alliance, or HRA, until December 23. I want to share my concerns about the performance of HRA, the Department of Health's contractor for animal control services and animal public health services, and its failure to deliver on commitments to DC. HRA is failing to meet many of its contractual obligations that we in DC pay for. These violations range from refusing to provide public low-cost spay and neuter services to failing to post monthly animal statistics online. Although the contract mandates that HRA treat animals with kindness and respect, I have not seen this treatment for well over a year at the DC-owned facility on New York Ave. Dogs live in stressful and dirty conditions, may not leave their kennels for days on end, and many deteriorate physically and mentally, sometimes to the point where they slam their bodies against kennel walls out of stress. Responsibility for this lies at the top, as animal care teams are always understaffed. This is astonishing for an organization with 40 million in net assets. The contract is only one part of HRA's failure to deliver on its commitments to DC public health. As a resident of Ward 8, I am very concerned that HRA is squandering taxpayer dollars that were intended to serve Southeast communities. Going back to 2010, HRA publicly touted its intent to build a state-of-the-art Southeast facility to provide all residents with access to better animal welfare services. In 2015, DC gave HRA $5 million for this purpose, which it used to buy a lot on M Street Southeast. Today, 9 years later, the property is littered with trash and a few shipping containers. It's an eyesore, a waste of valuable real estate, and HRA has refused to share its building plans when asked. HRA dabbles in temporary clinics and pop-up events throughout Southeast, and I've even heard that it might rent a space on Martin Luther King Avenue, Junior Avenue. But it has made zero permanent investment in Southeast, even though we taxpayers have given it money explicitly for this purpose. All the while, HRA continues to sit on the M Street lot and has failed to pay its property taxes since 2021. Currently, HRA owes DC $2.6 million. I see the impact of HRA's failures in my neighborhood. I have been offered unwanted puppies, some as young as 2 weeks old. My neighbors take in lost animals because HRA has told them it has no space. DC residents show more compassion and responsibility than HRA by taking on expenses and services that we are already paying HRA millions to do. I respectfully ask the council and the Department of Health to consider other contractor options, write a better contract with enforceable measures, build a new DC animal shelter that is more accessible to all residents, and ensure that DC grant dollars are given to organizations that have proven they can effectively use them. DC deserves public services that are the best in the nation, but for the short term, I just hope that we can get the basic services we pay for. Thank you.
Thank you. Ms. Bowens.
Good morning, Chairperson Henderson and staff. I very much appreciate the opportunity to present testimony today at the Department of Health's 2024 Performance Oversight Hearing. The important role DC Health plays in protecting the health of the district cannot be understated. The charge of the department is first and foremost protecting the public health of our vibrant city. The district's hospitals have a long history of collaboration with the department as we both endeavor to improve the health of our community. After our first 6 months at the helm of the department, I'm positive Dr. Bennett will be an even more formidable force of change, laser focused on improving health outcomes for our residents with equity and dignity. While a partner in promoting community health, DC Health also plays an important role as regulator for the hospitals, skilled nursing facilities, and health professions. Each year, the department conducts unannounced surveys at our facilities, as well as additional visits to investigate any complaints. Beyond local regulations, DC Health is also responsible for ensuring hospitals meet their obligations under CMS regulation. And this work ensures that health facilities are really meeting the needs of the patients in a safe manner, as well as providing care. In the area of collaboration, we're working closely with the department on improving maternal and infant mortality. As you are aware, Chairman, DCHA was awarded funding to establish the DC Perinatal Quality Collaborative by DC Health and is sought to receive additional funding from Developing Families, HRSA, to expand our work. And we are very excited that all of our hospitals, birthing hospitals, adopted the patient safety hypertension bundle. Hospitals are now reporting 100% patient support after persistent severe hypertension. Timely treatment of persistent hypertension has climbed to 92.3% from the baseline of 35%. Finally, scheduling postpartum blood pressure system checks for other hypertensive disorder during pregnancy is at 100%, up from our baseline of 0. And this is only the start of our work. One area we continue to urge improvement is in the area of the licensing of health professionals. We believe the department must ensure its technology is working properly and applicants are able to get their licenses timely. The licensure system must stop allowing individuals to submit incomplete applications, and HRSA staff must be available to assist applicants by phone and email when there are delays or issues with applications. In today's healthcare workforce environment, taking almost 30 to 45 days to process licenses is no longer tenable. We know that Dr. Bennett is focused on improving the system in a way that supports applicants and improves the process for staff as well. I would also, again, I have additional comments in my written, and so I'll end there. And thank you for allowing me to testify today. And I'm happy to answer any questions.
Thank you to this panel of witnesses. I think a lot of people, they have various interactions. Well, hold on. Let me put myself on a 5-minute. Thank you. Just so I stay on time. You know, I think folks interact with DC Health in a variety of different ways. But I think this panel is very indicative of just sort of the diversity of things that, and this is only a portion of it, right? Whether it be hospitals, animal control and care, home visiting, they have a piece of it, and school nurses, which is also like a piece of it as well. There's just a lot that's going on at DC Health. And so I appreciate all of you for testifying today. And I want to ask a couple of follow-up questions. Okay, so let me start with Ms. Thomas. I appreciate you being here today. We had a hearing on school nurses about 2 weeks ago. We continue to work with DC Health and with Children's on, one, the staffing for just this particular school year, but also as we go into the budget season around what are we budgeting for next year, and how can we improve. I think the question for a lot of school leaders is, would you rather have no one in your building as we are doing different things? But I think they also wanted some stability. But I think we learned from the hearing 2 weeks ago that there are some things that we haven't even done on our side. For instance, was it Prince George's County raised their salaries? And so given how compact we are, but we have to think regionally about how we do some of these things. And so we have some work to do on our end. And so we'll continue working on that. Ms.
Council member, we would like if you are working on the school nurses, that you would include experts in your panels to help understand the process. One of the things that nurses are finding in other jurisdictions is the Department of Health understands the nursing process in school health. That's the problem we're having here. Not just having a person in the building is not applicable because there are too many violations to our own guidelines.
Okay.
That's the problem that we're having here. More than anything, DOH is not following its own guidelines. They are allowing CSS to circumvent those guidelines and to create a model that is inappropriate because it's allowing unlicensed personnel to take care of vulnerable children.
Okay. Thank you again for being here. Ms. Lee, I want to follow up and so we've had extensive conversations with DC Health and with the Humane Rescue Alliance in the last, I feel like 6 months of lots of conversations about, one, what to do about the New York Avenue shelter, two, what to do about what happened to the $5 million, who owns the land, can we get the land back, XYZ. But DC Health says that the spay and neuter clinic is not part of the contract with HRA. Is that your understanding?
From my read on it, there are several sections in the contract that reference that HRA will maintain a public low-cost spay and neuter service of some kind. I'm happy to share with you the specific contract citations if that would be helpful.
Okay. That would be helpful just to sort of follow up on that. And to your point about Southeast, I think HRA is in a lease agreement or contract with Whitman Walker. So they're going to be in that old Whitman Walker space on MLK.
That's great. I hope it's a permanent solution and investment in Southeast communities.
Yeah.
Thank you.
But thank you for being here. Ms. Bowens, I wanted to ask about the Perinatal Quality Collaborative. So this is the part where I'm going to start referencing some of the data that we got from DC Health and the preparing questions. And frankly, like the training or the difference in hypertension catches pre-training and post-training was very remarkable for folks who haven't read this part. So part of the
trying to stay within my 3 minutes.
I know. Part of the Perinatal Quality Collaborative was training hospital staff on hypertension, preeclampsia, implicit bias, and respectful care for hospital teams. We had 95% participation from the 5 birthing hospitals. And before the trainings, 36% of women received timely treatment for persistent severe hypertension. After the trainings, it went up to 85%. I thought that the amount of money that you all receive in that grant is actually quite small for perhaps what more you all can be doing.
Yes.
Would you like to expound upon that?
Well, I mean, again, we got some initial funding and took over the program. And so we've had the combination of our hospitals making the commitment. And it's been, it's been difficult, but we've tried to find other resources in the interim. But to the degree that we could get more funding, we certainly can do more. But that's what we've been doing. We've been trying to supplement dollars as much as we can. And those are kind of one-offs. And to the degree that we could have some sustainability in the program, I think we have the opportunity to do so much more.
The grant that you all received in FY23, was that a 1-year grant or?
Yeah, we go back. Yeah, it's I'm pretty sure it's 1 year with the ability to get additional dollars, again, subject to availability.
Okay.
But initially just was 1 year. Yes.
Okay. How much would it cost to do the dashboard?
I don't want to give you the wrong number, but I'll get back to you and tell you exactly what that would look like.
Okay. Okay. We'd like to follow up on that.
Yeah,
to just sort of learn more.
Mhm.
And then also, and I hate to sort of ask you this question as I should follow up with MedStar, but when we did the maternal health hearing in December, we I had asked some questions around the new blood test for hypertension and whether or not any of the hospitals had taken that up. Excuse me. I think from MedStar, they said, it costs, I think the machine was like a few $1,000s. It wasn't sort of an.
Let me get back to you.
Okay.
I can get back to you on that and find
All
out. I can get you answers on that fairly quickly.
Okay. All right. I could probably keep going on and on, but there are other people here. So I want to thank
We can
everyone.
talk offline.
Thank you everyone for your thanks today. Okay, we're gonna go to the next panel. Anthony David. Elise Modesto. Sarah Buckley. And Fritz Malhauser. Okay. Mr. David, when you're ready.
Testing, all right. So good morning, Chairperson Henderson and Committee on Health members. My name is Anthony David Jr. I am a environmental justice community organizer with Empower DC. For the past 2 decades, Empower DC has worked to advance racial, economic, environmental justice with DC residents citywide. My testimony today emphasizes the urgent need for an environmental justice approach to address health issues in DC, particularly for residents in wards 5, 7, and 8. Historically, communities of color have been unfairly burdened with industrial sites, noxious waste facilities, and major roadways exacerbating health risks. Wards 5, 7, and 8 face compounded impacts evident in the climate crisis effects, lack of green space, and elevated temperatures. Wards 5 specifically, with only 29.4% of tree canopy coverage, bears 50% of DC's total industrial land area. This is very unsettling, as most of these facilities are congested around the Brentwood neighborhood. Facilities such as the Fort Myer Asphalt Plant, Department of Public Works Solid Waste Management Division, and many more facilities are all major source emitters. Residents have reported concerns of their health and safety related to air quality. Many residents have experienced not being able to open their windows for fresh air because of foul odors, dust, and other particulates in the atmosphere, and the consistent presence of engine idling by our own government vehicles. Due to climate change, heat emergencies, which means days where we will see temperatures above 95 degrees, will increase in our district. This will exacerbate the heat island effect that many overburdened communities have been facing and is projected to increase heat-related risks and morbidities such as heat strokes and heat exhaustion. Furthermore, insufficient research connects asthma allergens to disease outbreaks, despite evidence linking traffic corridors like the New York Avenue to high asthma rates. To address these issues, I urge the Department of Health and other agencies to form an interagency council for better program management and enforcement of regulations. This collaboration will safeguard the health of DC citizens and enhance living conditions for marginalized groups. The Office of Health Equity needs more capacity to support residents with health impact assessments and to contribute health analysis to plans to come out of Office of Planning, DOEE, and other related agencies. Residents in Brentwood, Ivy City, and other impacted communities urgently need the Department of Health to step in, and provide this type of analysis. Thank you so much for this opportunity to share this testimony. I'm looking forward to any questions. Thank you.
Thank you. Ms. Modesto.
Okay, good morning, everyone. Thank you for having me. My name is Elise Modesto. I'm a current Humane Rescue Society volunteer. I'm a former canine enforcement officer. I'm just going to highlight 2 of my main concerns. My colleague previously highlighted the humane animal population management surrender policies as where the non-existent policies are concerned. And that's in my written testimony, so I'm not going to really address that here. What I would like to address is the lack of accountability as DC Health maintenance of the animal care and control facility. So And what I mean specifically, it's going to be regarding the dogs labeled dangerous and pending litigation. So as a volunteer, I understand pending litigation, it's limited information and access that I have. What I'd like to reference is the treatment and the conditions that these dogs are living in. I'm referencing two specific dogs that are housed at the New York Avenue facility. They've been there. There's one mixed breed dog about 4 or 5 years old, lab mixed breed, as I said, and one bull terrier. They are labeled dangerous, and like I said, pending litigation. They are they have not been exercised in over a year, living in a kennel. Okay, to me, as a law enforcement officer, as a DC resident, as anyone working with animals, this is inhumane. So I would be remiss if I didn't address this and raise this to the concerns that DC Health has an obligation to ensure that we provide some type of professional care to these animals, to ensure that we have licensed, trained, certified, exercised professionals that can take them out. Excuse me, I'm repeating my words, but that can do this. We have officers that can wear professional gear, armed gear, protective gear. We have retired military law enforcement officers that do this sort of work, and DC Health can hire these folks. The other thing I'd like to say is also the conditions of the kennels, where they do need regular cleaning. It's not hygienic. I've been to the kennels. I would be remiss to say that unfortunately, these dogs are housed with the incoming population, where the dogs are distressed. So these same dogs that are there for years are also housed with the regular population. So in closing, I don't want to discount the good work that HRA has done over the years. I just wanted, as a new volunteer, I am highly concerned as what the conditions of the current facility. And I will close with that. Thank you for my time and to present to you. Thank you.
Thank you. Ms. Buckley?
Hello, my name is Sarah Buckley. I live in Southwest with 2 kids, including a kindergartner at Amadon Bowen Elementary School, and I'm a co-chair of our PTA's advocacy committee. I was here virtually 2 weeks ago during the roundtable hearing on the school nursing cluster model. And today I just want to address 2 aspects of DC Health's administration of the school health suites program. Briefly recap of remarks that I made on the new cluster model for school nursing, and also some brief remarks on the administration of medication training program. You heard this last week, but at a school level, Amadon has had inconsistent and disorganized school health coverage this year. We had no one in our health suite for the first full week of school. This particularly impacted me and my son, who has severe food allergies. No one was able to attend our son's 504 accommodations meeting, and no one reviewed his 504 plan or his medical orders for his EpiPen for months. After that first week, we were assigned a health technician who expressed she was not sure if she would be there temporary or permanently. Turns out she was both temporary and part-time. She was only in the building 3 days a week, but assigned to be in the building 3 days a week, but was often there less. When she was not there, we often had no one. And during that time, our students, parents, and staff felt the effects. Our principal saw long lines of students who needed to receive their asthma medication before going out to recess. Playground accidents resulted in calling parents. At one point, our front office administrator put out a call for more Band-Aids because she had so many playground accidents coming to her. Parents had to come in the middle of the day to administer daily ADHD medication for their children. And again, for us and for others with 504 plans, we did not have any consistent presence from the health suites program. So 2 weeks ago, we heard from the Department of Health that they had a drop from 90% staffing at the beginning to 56% in just a matter of months. So beyond our experiences, I think that's an indictment in itself of how DC Health has managed this program and how the cluster model is working. In addition, I have since heard of more well-off charter schools who, facing the chaos of the cluster model, have hired their own school health nurse. That is not an option for my Title I school that serves 60% at-risk population. So a brief note on the administration of medication training. DC Health has touted the AOM program as a backstop to the failures of the cluster model. But each of the last 2-year cycles for AOM training, our school has started without the required at least two staff with their AOM training. This appears to be a result of a backlog and bottleneck in the training program at DC Health. There was an incident, in fact, last year with a different student where our nurse was absent and the 2 AOMs were absent. He had an allergic emergency and needed an EpiPen, and they had to call EMS. So I would encourage council and this committee to ask how DC Health can streamline its training process, can provide more training at the end of a school year to ensure that every school can start its year with its AOMs, and to also take more initiative and to affirmatively track and ensure that every school has its trained AOMs. Thank you.
Thank you. Mr. Mulhauser?
Thank you very much, Madam Chair and members of the committee. I'm Fritz Mulhauser. I'm co-chair of the legal committee of the DC Open Government Coalition. I'm a Ward 6 resident for a half century, and I'm on the board of directors of our coalition. Thank you parenthetically for your support of open government in the police realm. We appreciate that. Look forward to working with you on it. I'm here to follow up on testimony last year. We came before you because of the department's difficulties complying with reporting requirements in the Death with Dignity Act. This was a remarkable statute passed in 2016, which allows DC residents who are terminally ill and competent to have the aid of a physician in prescribing and receiving medication that will allow them to humanely and peacefully determine their end of life. There was such controversy about the statute that Councilmember Che wrote a reporting requirement, a data requirement for annual gathering of facts and figures on the use of the program. There were very extreme predictions of trouble, and thankfully they haven't come to pass. But the reporting is not good. The department gathers data, but at present, there are years of unpublished reports still not posted despite the requirement in statute. We're asking you to add a requirement to statute so that the annual reporting of data on participants in the Death with Dignity program is reported. Why is it not being reported? We can't get a straight answer from the agency. You wrote last year asking them for a variety of reports to speed up their work, and they may have done it in other areas. I see the workforce report is out finally. But in this regard, they're simply not prioritizing this. An attorney in the office said, well, the council's recommendations to us are not requirements. There's no deadline for publishing these data. The public thinks that's unreasonable, and yet it's clear that the agency will not act without a reporting date being put into statute. Otherwise, it's just a polite exchange of views, and they're not going to change. This is not complicated. There's not thousands of people to be surveyed, or doctors or pharmacists. 7 people in the most recent report used the program. The reports that they have issued have 1 page of text, 1 chart, and 1 graph. That's it. Why aren't they doing it? I think they can get away with it, and they have for another year. Their website now, the most recent data ends in February of 2021. We think they can do better, and we ask your help through the Budget Support Act to send a message that there is a date every year when this data should be published. Thanks very much.
Thank you, Mr. Mulhauser, and thank you to this panel of witnesses. I'll start with you, Mr. Mulhauser. So I actually just pulled up the legislation. It says beginning 1 year after the effective date of this act and on an annual basis thereafter. I don't know off the top of my head what the effective date, but the effective date is the due date going forward, if that makes sense. So, let's see.
It's the view of
So it's supposed to be February 18th of every year.
the attorneys in DOH claim to read it differently. And I look forward to hearing the result of communication between the
Okay.
council and the executive.
We'll
on
follow up
this.
with them, as you noted, and for the public, I think I sent 3 letters last year to the city administrator about an array of reports that just were missing or in purgatory, because the agency said that they wrote it, they had sent it over here, and it had not made it out of review. So we'll follow up to figure out. I think we're only missing the 2022 report, or I guess 2021.
The last one that's published on the website was published in 2021. So it's data from 2020. So there's 2 more reports. The most recent would have ended in early 23. It's February to February. And so
Okay.
we're a year from having the 23 data
Okay.
report. So there are 2 that
We'll follow up all together.
Great.
I actually think in this particular case, especially with the reporting, for a law for which Congress, well, some House Republicans are so hell-bent on repealing, when we don't publish the reports on time, it looks as though we are hiding something, that something nefarious is happening, even though something nefarious hasn't happened. We just haven't done our part on the accountability side. So we'll follow up with them on that.
we appreciate it.
Ms. Buckley, it's good to see you again. Well, to see you in person, and I appreciate your continued advocacy. We'll ask more about the streamlining of the AOM training programs. I think that makes a lot of sense in terms of like, get it done before you leave for the summer. But it has also made me think about what training, if any, are offered to all of these out-of-school time providers during summer camps. Presumably there are children attending summer camps who need administration of medication. And so who's doing that? Which might be outside of the scope of DC Health, and we need to ask DPR a little bit more about that, but we'll definitely ask. Ms. Modesto, thank you so much for being here and for your volunteer service, as well as Ms. Lee with HRA. I agree with you that the New York Avenue shelter conditions is a problem, and it certainly has been one for a very long time. I think at one of the hearings with DC Health last year, it was after a particularly bad storm. I think it was like a wind, it was heavy winds, heavy rain. And I had asked, hey guys, have you gone out to, when's the last time you've looked at the building? And they said, well, we actually just sent someone out for a structural review because they were worried about the roof. And I just feel like it is, all of these are sort of combined pieces, but I think between the HRA situation as well as the Children's School Services situation, these are 2 instances where DC government has contracted out a critical service or a core function service, and in some ways also contracted out the oversight responsibilities of both of these as well. And we've been trying to do some catch up around, at least on the school nurses side, right? Like, I shouldn't have to call Children's to get data on who's in what building. I should be able to call DC Health and you know who's in a building at what time, because it is your contract, right? And it's similar with HRA, because they have been our contractor for so long, over 30 years at this point. I feel like there has just been this sort of, they're good, it's fine, when in fact there could be some more work there. We're going to follow up about the dogs labeled dangerous and pending litigation, as you noted. I know we recently did a tour of HRA. They talk about how they can't get into the specifics of a case, which is fine. I don't need the specifics. But if a dog not having been exercised in over a year, that is, I don't see, how can anybody think that that's okay? Sure.
Absolutely. And I understand that the dog may be dangerous, but like I said, the fact that there isn't the protective gear on site that anyone could wear or procure, I wear it, even for a puppy. So just some of the things that I think some of the processes are archaic. And so But thank you. I appreciate that you're going to take a look at.
Yeah, and I actually think that it's not an oversight hearing for HRA, but HRA is testifying later, so we can follow up on some of this. Mr. David, thank you so much for being here and for your testimony as well. We've had conversations with both Children's and Howard about some of the work that they have been doing around air quality and the impact on asthma rates and health outcomes and things like that. I want to ask though, I think in your testimony you said you wanted a task force. Are you sure you want a task force? Considering we can't get reports out, like, what is it? What in an ideal scenario, what would happen?
So here's what the problem is. I feel like, especially when tackling environmental justice, it's hard to get a lot of agencies into the same room because there's a lot of, different things that are happening. So for example, the W Street bus terminal that's being built by Aussie or by DGS, there's no transparency. They came out with a report saying that they found water, like a wetland on top of the site, and that they found, a perennial stream. But then they're backtracking saying that, oh, there is no wetland, but there is still a stream, but there's no clarification if that stream's above ground, underground, and plus on top of that, if they're under a permit review for a stream, they are supposed to stop construction, but yet construction is still happening on that site. So it's just a lot of, missing pieces when having conversation. We'll go to DOEE about an issue. They'll be like, oh, that's the DC government's job. We'll go to DC government. Oh, that's DOEE's job. And then the EPA will get involved. And it's just like, oh, actually it's everyone else's job. And then even with the construction sites as well, even through DGS, they aren't super clear about what's, going on, or like what their proper steps are supposed to be. And like I said, even with some of our government vehicles, a lot of these people don't understand how long they are allowed to idle. We will interact with some of these people and they're just like, oh, I'm allowed to idle for 15 minutes. And when the regulation says, only 3 to 5, so it's just a lot of missing pieces and a lot of miscommunication that's not happening throughout the agencies. And I think because DC is not a state, we don't necessarily have a environmental justice, advisory board or anything like that, or anything that's looking at environmental justice. DOEE is just a advisory type of agency. They don't really do enforcement, and they don't even have a diverse, as of last hearings of last year, they didn't even have a diversity or equity, person, for that agency. So how are you going to talk about and address environmental justice if you don't even have like that equity component, so it's just a lot of missing links.
Okay. Yep. No, I mean, even as you're sort of talking, I'm thinking about, all right, let's say if we wanted to talk more about the W Street project, that's not my committee, but it's like Chairman Mendelson, the committee of the whole, because he has Aussie. It would be Councilmember Lewis George with Facilities and Family Services, because she has DGS. It would be Councilmember Allen with Transportation and Environment, because he has DOE. So even in that case, it would have to be like a joint, everyone sort of, I hear your point. I just am sort of like, could a task force deliver on what you're trying to get at? Or should we be asking DC Health and the Department of Energy and Environment to be more aggressive in sort of pushing into these conversations about some of these projects that are going to impact the health of the surrounding neighborhoods and communities?
Yes, one more thing that I would like to add, is because I know Councilmember Zachary Parker, just introduced the, Environmental Justice Amendment Act that, gets at, having that cumulative impact assessment, which hasn't necessarily, been done historically in DC. For example, the National Engineering Products has been operating, and their facility shares a wall with a family. This is a chemical facility. So the fact that, a house that's built by the DC government is sharing a wall with a chemical facility, certain things like that is just not happening. With my work, a lot of my work is previously from the state of Pennsylvania. And, when thinking about, when you're importing a lot of these different facilities, you need buffer zones, you need things to help mitigate a lot of these different types of emitters. It makes no sense why a lot of these industrial sites are congested into one area. There's no health, insights on that. There's no.
But in that particular case, right, think about it from like a Ward 5 perspective, which has the most industrial land in the city, that was to reverse over 100 years of city planning, right, in that realm, is like just sort of a very large undertaking. In the case that you're talking about with Ivy City, right? The plant was there before the house was there. I don't know who made the decision to build the house there. And someone in government at that point should have stopped it then and said, from a zoning perspective, you can't share a wall. But we'll keep thinking more about that. I'm on Councilmember Parker's bill. And I hope that we can see that move forward. But thank you for being here. Thank you to this panel. Appreciate you being here. Oh, shoot. I'm so sorry. No, thank you guys. I didn't realize that there was only one person left in person. But if there's anybody in the chamber who wanted to testify who didn't sign up, I only have 4 chairs anyway. It's okay. Come on, Mr. Dickey. No problem. Just you got to just turn the mic on.
My name is Willem Dika, and I coach soccer through DC Scores at Amidon Bone Elementary, where my daughter also used to be a student. I'm testifying today in my own individual capacity and not on behalf of DC Scores. I would like to commend the courage of my friend Sarah Buckley, the co-chair of the Amidon Bone Advocacy Committee, of which I'm also a member, for her courage and that of all the other parents who have come forward with their very private stories to highlight the failure of the new nurse cluster model. This issue, like so many others since I've been active at Amidon since 2017, has taken on significance beyond just the category of things that you know to be intellectually true. Now, I told this committee 2 weeks ago that I was working with our school's PTA to fund Red Cross training and AOM training. Under the new cluster model, Amidon's full-time nurse was replaced by a health tech that is only present on 2 or 3 days per week. And this, along with the statement that this committee to this committee 2 weeks ago by the CEO of Children's Health Services, that nurses are essentially off the clock after school ends at 3:15, means that I cannot rely on the presence of a nurse or AOM trained staff that may have gone home for the day. Now, Chairperson Henderson, you described this situation superbly as YOLO. You only live once, as in after school staff and coaches, you're on your own. You added that as a parent, you would be asking, quote, what are we doing? The PTA is reluctant to fund the Red Cross training because of liability concerns, but I will nevertheless undergo both the first aid and AOM training and pay the cost myself, because in case of an emergency, I feel a duty to my students to at least know the basics of EpiPens and asthma inhalers, since there may not be someone at the school. Now, I will upload, along with my testimony, a summary video of the January 4th Oversight Roundtable held by this committee, because in juxtaposing and piecing together the testimonies of the government witnesses with their answers to the follow-up questions, there are inconsistencies and contradictions that are not readily apparent when watching the raw 3.5-hour footage. For example, the choice faced by DCPS schools last year was not a full-time nurse or nothing at all, as DC Health asserted. Also, the public testimony showed that the lack of a full-time nurse, especially in the wards of our city with the most student medical needs, is not just a matter of health and safety, but that under the new model, reassigning nurses from schools they have served for years poses a threat to the fabric of many communities. Many are desperate for action, but in many cases are hesitant to come forward or feel that their voices will not be heard. The second takeaway from reviewing the January 4th Roundtable and other sources is the overwhelming support of a return to a full-time nurse in every school. Mr. Mendelson and Ward 6 Councilman Charles Allen attended our January 8th Ward 6 ANC 16 meeting. Mr. Mendelson stated, and I quote, I am confident my colleagues support a nurse in every school. Now, hearing statements like that from the chair of the DC Council, coming on top of all of the groups and individuals I mentioned, the parents, school staff, the failures of the cluster model does beg the question, what are we doing?
Thank you. Thank you for your testimony. And I just asked my staff to make a note. 2 weeks ago was very illuminating, especially
Yes.
from the perspective of what happens after school.
Absolutely.
And it has definitely got me thinking more around what are the guidelines, training requirements, et cetera, for folks who do after school or coaches who do sports in our schools, whether it be elementary, middle, or high school.
Right.
And so we're going to ask more in the education cluster about this. I think that's where the what is it? DC Athletic Association is in committee of the whole, but it just seems like a sort of accident waiting to happen here.
Absolutely. Yes.
In that things happen after school. If we think about the idea that many aftercare programs go to 5:30 or 6, and if there's nobody at the building from, what did she say? 3 or when
After
3:15?
Yeah.
To 6 o'clock, who could provide any sort of medical
Yes.
care without calling 911. I think that is most certainly a concern.
Absolutely. And I think for many people, right, this is an accident or even a death waiting to happen in the current situation. So.
Yeah. Okay. So we'll follow up some more on that. But again, I appreciate your advocacy and thank you so much for being here.
Thank you very much.
Okay. That was my last in-person person. And so we're going to switch to our virtual. We've only been going for an hour, so it kind of seems weird for me to take a break. So I'm going to go ahead and call 1, 2, 3. I'm going to call the first 8, and then we'll go from there. So for those who haven't done a virtual hearing with us before, you need to affirmatively accept our invitation to become a panelist in order for you to come onto the screen. So Mary Catherine West, Claudia Schlossberg, Veronica Sharp, Mark Miller, Delilah Boaklin, Catherine Benny, Emi Yamaguchi, and Jaron Hill. So we'll give it a minute for those folks to enter into the room. Again, you have to affirmatively accept our invitation to be elevated as a panelist. Okay, while folks are coming in, I see Mary Catherine. So Mary Catherine, why don't you go ahead and get started? Oh, hold on 1 second, Mary Catherine. We can't hear you in the room. Can you try speaking again? Okay, hold on 1 second. Let's see. Claudia, can you come off mute and let me just see if I can hear you, if it's us or.
Sure. Can you hear me?
Yes, I can hear you. Okay, so Miss West, if you can. No, we still cannot hear you. Make sure you just check the mic. Okay, I'm going to go to the next person and then come back. All right, Claudia.
Thank you and good morning, Chairperson Henderson, members of the Committee on Health. My name is Claudia Schlossberg. I'm testifying this morning in my capacity as chair of the DC Coalition on Long-Term Care's Workforce Development Subcommittee. As you know, the Coalition on Long-Term Care brings together consumers, advocates, providers, and provider associations, as well as organized labor to improve access to high-quality care for district seniors and people with disabilities. We know that access to high-quality care depends in large part on having a sufficient workforce to provide needed hands-on care and assistance. And the Department of Health, particularly the DC Board of Nursing, plays a vital role in helping to ensure that there are sufficient qualified workers at all levels to meet the support and healthcare needs of our growing aging population. We have testified, at least for the past 4 years, to raise awareness of the direct care workforce shortage. We have not only testified, but we've brought forward recommendations, many of which have been incorporated into the Mayor's Healthcare Workforce Task Force, which was convened in the summer of 2022. And while we're pleased that the Department of Health has indicated some interest in developing reciprocity agreements with CNAs for CNAs and home health aides in Maryland and Virginia, and is open to making some needed upgrades to the Health Occupations Regulations Act and some changes in the licensure procedure, overall, the pace of reform has been glacial. In the absence of meaningful reforms in the past 4 years, we have seen an alarming reduction in the number of home health aides and direct care workers. During the last direct care worker renewal cycle, which ended on October 30th, 2023, the number of home health aides went from 8,380 to 6,683, a loss of over 1,700 aides, or more than 20%. The number of certified nursing assistants, who mostly work in nursing facilities and assisted living, went from 5,103 to 2,756, an astounding reduction of 46%. And the number of medication aides, trained medication aides, declined 30% during the same period and 50% from February 2022. These people cannot work without certification past December 31st of 2023. While we are unclear exactly what has caused this precipitous decline in the number of aides in DC, we know that the recertification process itself was a barrier. And we did have conversations with the Board of Nursing regarding some of the needed changes. Many aides, in fact, probably the vast majority of aides, could not get through the process without significant help from their employers. In addition, as you believe are aware, DHCF, the Medicaid agency, rolled back provider payment rates for nursing facilities and home health aides that were paid during the pandemic to eliminate reimbursement for overtime and enhance reimbursement rates. And we believe that also has had a major impact in people leaving the profession. Not only have we lost nearly 40% of this vital workforce, but the number of students coming into this profession is much lower. Based on some data that we received from the Board of Nursing, we've seen I think it was 2018, there were 1,078 home health aides and CNA students who passed the certification exam. But in 2021, which is currently the last year that I have data for, there were fewer students and only 798 passed the exam. These numbers should be setting off alarm bells. We see little evidence, though, of a sense of urgency on the part of the Department of Health, and we continue to be concerned about the lack of coordinated response among various agencies. We believe that the mayor may need to use her emergency authority to authorize DC Health to revive pandemic-era waivers that allowed Maryland certified nursing assistants to work in DC as CNAs and home health aides. And we believe that DC CNAs should also be allowed to work in home health without taking the bridge course. I have included multiple additional recommendations in my testimony. We are still waiting for medication aid training, a program that was finalized in 2019. We're still waiting for that. We're still waiting for the release of funds for the High Needs Health Career Scholarship Program. And we know that many of the recommendations that we have put forward are embedded in the Direct Care Worker Amendment Act of 2023, and we would urge the council to move that legislation forward expeditiously. I will end here and I'm available for any questions. Thank you.
Thank you. All right, Ms. West, you want to try again?
Are you able to hear me now?
Yes.
Hello.
Can you hear me? I can hear you.
Okay. Great. Yes. Okay. Good morning, Chairperson Henderson. Thank you for the opportunity to testify today. My name is Mary Catherine West, and I am the program coordinator for the DC Home Visiting Council at DC Action. I am a member of the Under 3 DC Coalition and a Ward 1 resident. We appreciate the council's recent support for home visiting and DC Health's partnership with the Home Visiting Council in 2023. We look forward to continuing this collaboration. DC Health's home visiting programs are critical within the district's overall home visiting landscape. The 17 federally, locally, and privately funded programs served over 2,600 parents and children across the district, delivering 22,799 home visits in 2023. Home visitors most often help families navigate income, employment, or financial stress, finding safe, affordable, and stable housing, food insecurity, mental health, immigration, and domestic violence. By assessing family needs, educating and supporting parents, and referring families to community resources, home visitors support the needs of both parents and children. This results in improvements in school readiness, healthy birth outcomes, family economic security, and reductions in child abuse and neglect. There have been rumblings of mid-year budget constraints and the health and human services sector, and I strongly caution against any cuts to home visiting programs this year or next. By contrast, home visiting needs more public investment, either from federal or local sources, to maximize its potential to reduce Black maternal health disparities, prevent adverse childhood experiences, pursue meaningful improvements to administrative processes and staff retention goals. Budget cuts and even the threat of budget cuts destabilize programs and disrupt family continuity in them. At the December 2023 Maternal Health Roundtable, DC Health acknowledged the need to improve home visiting programs, workforce recruitment and retention, and reimbursement for services. The district must follow through on these commitments because ultimately families bear the consequences. Losing a home visitor creates instability in a family support system and a potential gap in access to critical resources. In 2023, the majority of home visiting programs reported continuing challenges in retaining and hiring staff. The average salary for home visitors in a DC Health program is $48,125. These salaries are not competitive in the field and inadequate to support a living in DC. When home visitors leave, programs struggle to hire at a rate equal to attrition. Some programs report reductions in their grants when positions they are trying to fill remain vacant. Instead of fueling recruitment, programs face disinvestment from DC Health. Alongside improving communication and transparency with grantees so they can effectively plan for the future of their team, we recommend maximizing federal investments and increasing grants so that home visiting programs can pay home visitors thriving wages to continue to support DC families. Thank you for the opportunity to testify, and I welcome any questions.
Thank you. Ms. Sharp?
Yeah, I was trying to come off mute. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Veronica Sharp, and I'm the president of the District of Columbia Healthcare Association, which represents all of the district's licensed nursing facilities and several assisted living communities and the nearly 3,000 district residents to whom they provide care. DCHCA members had the opportunity to meet with Dr. Bennett this week and brought her up to date on our areas of concern. The first area of concern is the workforce crisis. The long-term care sector has been the slowest to recover, and we believe this is due to the inability to pay a real living wage. And you can this is a hard job. It's hard to do, and you can work elsewhere and make more money. So it's been hard to recruit. But what we need from the Department of Health and the Board of Nursing is to be able to streamline the renewal and licensing process to be able to get people recertified and also to be able to recruit nurses from neighboring states. Nurses from other states often tell us the process in DC is so difficult to get through that we just don't bother. We give up trying, and we'll work in Maryland and Virginia. The other thing we need is that for the educational requirements for CNAs and home health aides to be offered in one course so that an individual can work in both settings without a bridge course, which is just another expense for those individuals who are not paid enough to begin with. The age for certification also needs to be lowered to 16 so that individuals interested in long-term care can begin working sooner. The other workforce issue that we asked Dr. Bennett to look into is a case-by-case basis of waiving the 4.1 hours of direct care per patient day. During the public health emergency, there were waivers given, and even though the PHE has ended, the nursing and direct care workforce shortage still exists. Being required to staff at that level when you can't recruit workers causes increased agency use, which is not as good a care as your own team. And it also increases expenses. And if there's difficulties in finding board candidates, and we are currently actively recruiting our members for volunteers. Finally, the other area of concern is that with the change in leadership and the public health emergency, the working relationship with HRLA has not been as close and members look forward to reestablishing regular interaction and technical assistance opportunities. Finally, members asked Dr. Bennett with assistance with COVID testing supplies with current uptick in cases, and that was quickly met, and I'll be picking up testing kits tomorrow. Thank you for your leadership, Chairperson Henderson, and I'm happy to answer any questions.
Thank you, Ms. Sharp. I called for Mark Miller, but Pearlie Jones is going to testify in his stead. Mr. Jones?
Thank you. And greetings, Chairman Henderson and members of the Committee on Health. I'm Pearlie Jones, the Program Manager for the Office of the DC Long-Term Care Ombudsman. Thank you for the opportunity to testify today on behalf of the 9,000 residents receiving long-term care services and supports in nursing homes, assisted living residences, community residential facilities, and in their homes through the district's elderly and persons with disability services. The Ombudsman advocates for the rights of the residents, the most vulnerable population in our long-term care facilities, and we promote and ensure the highest quality of life and the quality of care for the individuals receiving those services. In fiscal year 23, the Ombudsman program investigated 226 complaints, resolving 83% of those issues to the satisfaction of our residents. Our office also is one of 13 Ombudsman programs in the country that serve persons receiving long-term care services in the community, specifically to the EPD waiver program. I'd like to highlight a couple of points this morning. One will be our long-term care study project, and the other will be addressing systemic issues. First, in 2019, with the support of the committee, the council passed and funded a long-term care facility study and through the Long-Term Care Services Act. And given the shortage of the nursing home beds and the lack of affordable assisted living, this study has been critical or was critical to the need. After a long delay, at least a year, it was finally released in 2023. Unfortunately, it yielded very little answers. For instance, the report accurately states that in the past 10 years, the district lost 439 nursing home beds. And it also states that individuals 65 and older would face 70% chance of being in need of nursing home care. We need to focus on building an infrastructure, but there are still concerns about health equality and gaps in services. Second, in terms of systemic issue, our office has been working with HRLA to update the model discharge plan, and we are still working on this. The plan has not been updated in the past 15 years. Also, we'd like to raise the issue of not receiving notification when the surveyors go into the long-term care facilities. This is critical for the Ombudsman's input, as well as assurance that the residents' rights are being met. Thank you for the opportunity to speak today on behalf of the district's vulnerable residents receiving long-term care services and supports, and I welcome any questions.
Thank you, Mr. Jones. Ms. Buckland?
Good morning, Councilmember Henderson. Thank you for convening today's hearing. My name is Dalila Bachlan. I'm an independent food systems consultant with specific expertise in regional food systems, and I'm here to share my perspective on how DC Health has been instrumental in supporting food access in farmers markets across the city and provide suggestions for how the city can enhance this impact. Before becoming a consultant, my professional experience includes developing food access and resiliency programs at various for-profit and nonprofit institutions, including Fresh Farm, the largest farmers market organization in the Mid-Atlantic. I also served as the executive director of social impact at Hungry Harvest, where I launched and grew food as medicine interventions with dozens of regional partners, including Medicaid managed care organizations, hospitals, and social service agencies. Since May of 2020, I've served as an appointed member of the DC Food Policy Council, where I co-chair the Sustainable Supply Chain Working Group, and the testimony provided here is consistent with the comments and workshops that the working group has received and completed to date. First, I encourage the council to understand and approach support for farmers markets as part of our strategy to enhance food resilience and support food access for underserved communities. Farmers markets are a unique market channel for local producers and an essential food access point for vulnerable communities. Thanks to their shorter supply chains, unique supplier networks, responsiveness to vulnerable communities, and reduced demand on public infrastructure, farmers markets are able to address food resilience and access more nimbly, affordably, and in non-duplicative ways relative to other interventions. Furthermore, farmers markets activate public spaces, transforming roadways into safe, community spaces that welcome residents from all walks of life, while also driving revenue for locally owned brick and mortar businesses. For example, one cafe in front of the Bloomingdale Farmers Market cites an average of a 50% increased revenue during farmers market hours. DC Health's Produce Plus program has been both a successful and efficient program for supporting farmers markets by enhancing purchasing power among residents with lower incomes. This year, the program supported over 7,000 individuals with increased access to fresh fruits and vegetables, directing over $1 million to local producers and resulting in expanded farmers market operations in lower income areas of the city. For example, just this year, Fresh Farm opened a new farm stand in Ward 8 at the Anacostia Community Museum. Furthermore, the program's utilization rate has exceeded 95% since it was first introduced in 2014, which dispelled myths that lower income customers do not feel welcome at farmers markets. Rather, when individuals have the purchasing power, they more than willingly travel to their preferred farmers market across the city and exercise choice for their favorite local seasonal produce. In fact, the Produce Plus program has a waitlist of nearly 4,000 individuals throughout the 2023 season. I urge the council to expand funding to $2.5 million a year for Produce Plus in order to serve more residents, thousands of whom have already demonstrated interest in consuming more fresh fruits and vegetables. I have additional recommendations in my written testimony, and I appreciate the opportunity to speak before you today.
Thank you. Catherine Binney.
Hi, my name is Catherine Binney. I've lived in both Georgetown and Eckington and Northeast in DC over the last few years, and I volunteer walking dogs for the Humane Rescue Alliance, DC's animal control and care contractor. I've been engaged with a group, HRA Volunteers for Reform, to think about animal care and control in DC. My commentary is on DC Health's duties related to animal care and control. First of all, according to DC Code 81810, the mayor, who then delegated the responsibility to DC Health, will implement an education and incentive program, which is to include low-cost spay and neuter services. Low-cost spay and neuter services are not currently available anywhere in DC. In addition, according to the code, there should be a special fund, the Animal Education and Outreach Fund, that is funded through dog licenses and cannot be converted into the unrestricted fund balance of the general fund of the District of Columbia. According to a recent inquiry, that money has in fact been converted to a general fund. I believe DC Health needs to establish low-cost spay and neuter services, either through a contractual obligation that is very specific to be fulfilled by HRA, the current animal care and control contractor, or through a different service or contract. Currently, HRA is sometimes adopting out animals pending spay and neuter, given a very long internal surgery waiting list, and doesn't seem well equipped to be contracted for this service. Secondly, I'd like to request additional transparency in animal control. According to Code 8-1802, the Animal Care and Control Agency has to ensure all contractually required records are accurate, easily accessible, and available at all times. After reading some recent concerns about HRA, I requested access to said records through the Freedom of Information Act with a specific request for the records HRA is required to provide on a monthly basis according to their contract in order to determine whether those concerns had merit. DC Health has been unable to acquire those records for over 3 months, despite a much shorter required FOIA turnaround time. It isn't clear whether this is coming from HRA refusing to provide them or otherwise. HRA also does not post contractually required monthly statistics in the animal care and control facility. Thirdly, I am concerned about DC Health through HRA not fulfilling the requirements of 8-1802 to promote the reduction of euthanasia of animals and utilization of trap, neuter, release to control the feral cat population. I've seen a recent petition noting that in January alone, HRA euthanized more than 15 dogs originally classified as adoptable. I've also heard concerns from volunteers that their friends who work with community cats have struggled to get TNR, trap, neuter, release slots and have had HRA turn away kittens. Finally, I am concerned about DC Health's maintenance of the animal care and control facility on New York Ave. The facility is not large enough to house the animals impounded and surrendered in the district and has had issues with things like maintaining appropriate inside temperatures and safe outdoor spaces to take yards. The yard is very muddy and slippery. I believe DC needs to build a new animal care and control facility in an accessible part of the city that can serve the current needs of the population, including the ability to provide low-cost spay and neuter and provide humane conditions for the housed animals. I'd like to see this be a government-owned property and an easily accessible part of the district to ensure there's continued public oversight over the facility and the work completed in it. Thank you so much.
Thank you, Ms. Binney. Emmy?
Yes, hello. Thank you for this opportunity to testify, Madam Chair. My name is Emmy Yamauchi. Until last September, I had volunteered for 14 plus years at the Washington Humane Society and then for the Humane Rescue Alliance, primarily as a foster parent and as a medical assistant in the spay-neuter clinic and vaccine clinics. I am a current and increasingly concerned donor. My concerns about the district's animal control contract with HRA center on the two services which contribute most to humane animal population management and to a healthy animal population living with humans, safe from animal-borne diseases. These are the low-cost spay-neuter procedures and low-cost vaccines. How does the denial of these services negatively affect district residents, their pets, and the quality of life in our city? Spay-neuter is regarded as an effective method of population management. A low-cost program keeps pets together with their families, without unplanned or unwanted litters, and without irresponsible fathers running around. Since HRA has not offered low-cost sterilization services to the public since September 2019, there have been at least 4 or 5 unwanted or unplanned for generations of puppies and even more litters of kittens born. Dogs and cats become fertile after 5 months of age, and pregnancies last only 9 weeks. That's a lot of babies. One has to ask whether the overcrowded and unsanitary conditions at HRA are the result of HRA itself eliminating its own low-cost spay-neuter program. The contract says HRA is supposed to provide low-cost spay-neuter services to the public, but the truth is it has not for 4+ years. District residents, instead of paying $200 to $300 for spay-neuter, are now paying $600 to $800 at a private veterinary clinic, if they can afford it. There are also no more regular low-cost vaccine clinics at HRA's main location, where they used to vaccinate as many as 250 animals a week. Those clinics have been suspended since September 2023 until further notice. The contract mandates HRA to offer vaccine clinics 10 hours a week. Instead, HRA vaccinates in a trailer van for a total of 5 hours every other Friday, and the occasional pop-up vaccine clinic. But as any pet parent can tell you, puppies and kittens need a series of baby shots at regular intervals between the ages of 6 to 18 weeks, and the all-important rabies vaccine as soon as possible after 12 weeks. Every other Friday and sometime pop-up sites do not meet these needs. Again, the result is DC residents, instead of paying $15 to $25 per shot, pay $50 to $75 at a private practice, if they can afford it. The Humane Rescue Alliance has failed to provide important contract services. It blames the pandemic, but the truth is spay-neuter shut down 6 months before the COVID lockdown, never to reopen. And the low-cost vaccine clinic suspended almost 2 years after we emerged from lockdown. As a pet owner and DC taxpayer, I respectfully urge the committee and the DC Council to hold HRA accountable. Please strengthen the terms of any future contract with specific definitions, quantifiable requirements, humane care standards and SOPs, and enforcement mechanisms. Thank you very much for your time and efforts.
Thank you. And last one on this panel, Ms. Lockridge.
Yeah.
Say it again. Me? That's me, right?
Yeah, that's you.
Okay, cool.
Sorry, Ms. Sharp, if you could go on mute, if you can hear me. But go ahead, Jaren.
Good morning, Chairperson Henderson, and all of my esteemed peers and folks on the council. Thank y'all for the opportunity to be here. I'm Jaren Hill Lockridge, and I'm here as chair of the Ward 8 Health Council. You know, the woman that built the well, Ward 8 resident, mother, all things trying to make sure that we're better in the great Ward 8. This is now my third year as chair of the Health Council. And one of the things that I'm really excited that has happened under my leadership is we have these priority areas, right? Last year, it was maternal health care, where Chairperson Henderson, you were instrumental in helping us understand the needs and assessing kind of our healthcare landscape as it relates to that. The second one, senior quality of life. If you've heard me say it once, you've heard me say it 1,000 times. I stand on the shoulders of giants such as Calvin Smith, Marion Barry, James Bunn, William Lockridge, and also Councilmember Vince Gray. You know, the work that he gave, the work that he's been doing to support the Health Council since its inception, as well as in his various roles, it does not go unnoticed. And then the last one has been workforce development, recognizing that we have the new hospital coming over, the relocation of the Department of Health to the Great Ward 8, just really trying to understand what does that mean for our workforce development and our healthcare landscape. And this year, really excited to include a fourth one as well, that being behavioral and mental health, recognizing that those first three really can't be addressed without understanding our mental needs and our mental awareness. With that, you know, we meet the third Wednesday of every month, and really excited that this year we're trying to do a comprehensive calendar where we can understand all of the Ward 8 health and wellness related events, because there's so many things that come up, whether that's the resources to the block, the health fair that just happened, the maternal things that we've done together. So really trying to understand kind of what our healthcare landscape calendar looks like on the front end, while also understanding that with the relocation of the Department of Health over to the community, as well as with the building of Cedar Hill, what does that really mean? And I'll end with kind of two questions that I have, you know, on behalf of the Health Council. The first one, you know, as I've said, when the Department of Health moves over, what does that mean? How is that going to change our access? Will that mean that we have more access to that? Like, just what does that mean? Like, really, what does that mean? So excited to have more conversations with Dr. Bennett. And then the last one, you know, healthy environments create healthy people, and healthy people create healthy environments. With the restoration of Oxen Run Creek, which is going to be one of the largest infrastructure environmental changes in our community, wanting to know how we can coordinate the health needs with the environmental needs and the assessment of Ward 8 residents. Again, I'm here to say thank you for all of your support and here for any questions that you may have.
Thank you. And thank you to this panel of witnesses for your testimony and for being here today. I have a few follow-up questions. Mr. Purley, I want to start with you. Thank you so much for being here. I wish you could have seen our reactions here, sort of giving your testimony around the model discharge plan and sort of the delays in updating that plan. Ideally, what's the ideal period of time for updates to the model discharge plan? I think you said in your testimony it hasn't been updated in about 15 years, but what should it be? You're on mute, Mr. Jones.
I think the update should change according to the need or priority. I think we've seen trends here towards managed care models, which sort of introduces a new perspective on long-term care. However, you know, when we're addressing discharge and termination of services, These concerns or issues represent the largest complaint category that we have to address. And I think we have to maintain a priority on that, and there needs to be a coordinated effort. So in this particular sense, this conversation has been going on for at least the past year, and there has not been an update or a consistent model that everybody can follow. And so I think there's an urgency to get it done. So whenever the priority changes, I think with our trend towards the MCOs, I think it's a matter of making sure that they're on board so that there's a consistent effort in making sure that there's a process in place for avoiding the eviction of some of our most vulnerable adults receiving long-term care services and supports.
Okay. Thank you for that. We'll certainly follow up on that front. Staying on the long-term care theme, it's funny that there's a group of you on this panel that specifically were asking questions about that. Ms. Sharp, I wanted to follow up on something you mentioned in your testimony. So a week ago, we had a hearing on some nominees for the Board of Long-Term Care Administration. And they testified that they were generally supportive of the move of the Long-Term Care Board into the Board of Nursing. What are your specific concerns with that?
Well, number one, that it becomes nurses making the nurse process is totally different than an administrative process. I mean, administrators are not clinicians by nature. I'm sure they've picked up as their time as administrators have picked up on what has to happen in their building, clinically for residents. But it's more of a management, administrative, and strategic planning role, which is not to say, that's necessarily the skill set of nurses. We want to be able to be judged by peers, by people that are educators of long-term care administrators, by people who have worked as long-term care administrators, by people that have received those services, and not necessarily by and some administrators may even be nurses. But I believe that there's a federal, because we're so regulated, I believe there is a federal statute that says that the board can't be represented by a majority of one type of profession. So with all of those folks being nurses, basically nurses, I think it would fall under that statute and shouldn't be allowed.
Okay. We can follow up on that for those who are trying to figure out what we're talking about here. So the committee is also considering the bill called the Health Occupations Revision, which proposes a number of changes to the health professional boards. And even though that's not this hearing, we wanted to definitely take the time to sort of get some feedback on that front. Ms. Schlossberg, thank you so much for being here and for your continued advocacy. I'll just say, as we've communicated, we are, the committee I introduced a bill on direct care workforce. And so we're going to be looking to hold a hearing on that in March. So after performance oversights are over, but before budget. So we'll be able to get into more in depth some of the issues that you raised and continue to raise. Although we will be asking DC Health some questions around the home health aid. I don't know if we can call it a crisis yet, but
Thank you, Chairman Henderson. We very much appreciate your leadership on these issues.
All right, thank you.
And your persistence in following up. Thank you.
Okay. Ms. West, so in the performance oversight responses that we sent to the DC Health, we asked for a range of the salaries for the home visiting grantees, because I remembered last year during performance and budget oversight, we had a number of people who came to testify who said we needed to increase the funding because the salaries were so low. So looking at the range, they range from $46,000 to $54,000. So there seems like there's some flexibility among organizations, which is something that DC Health had mentioned, right? We don't set salaries. Organizations, some do certainly pay more than others. what do you all feel like should be the balance between DC Health providing organizations the flexibility and I guess setting of a floor, or like in terms of what the coalition is asking for here? I don't think it's necessarily appropriate for the agency to say the salary must be X.
Yes, so in our 2021 policy recommendations brief for compensation and workforce, setting a salary scale to put home visitors' salaries on par with the related industries and home visiting programs across the district was one of the potential recommendations. However, we haven't had forward movement with DC Health to pursue that recommendation. So the other recommendation was to have home visiting programs increase their grants through DC Health. So we see this in CFSA. Last year, increased their home visiting grants to specifically bolster the wages of their home visitors in CFSA home visiting programs. So as the council has not moved forward with that salary scale recommendation, we still want to push forward the increase in grants for wages.
Okay, but even if we were to say we're increasing the amount of your grant and express that this is the purpose for salaries, we wouldn't control that, if that makes sense. Let me give you an example. In the charter school space, for instance, we increase the facility allotment for charter schools, but the district doesn't control whether or not a charter school spends it on facilities or whether or not they spend it on salaries. So I think it's a question of, or I would ask, as you guys in the coalition are sort of working towards budget, is that we get more clear on specifically what you want. Is it the salary scale, or do you want a floor, or like the tangible sort of outcomes? Because it seems as though you all don't want to leave it to chance for an organization to be able to kind of decide. And so we just need to get really clear on what it is you all are asking for. But thank you so much for being here. Ms. Bachlan, thank you so much for your testimony as well. I recently had a briefing with Fresh Farm, and being able to see just sort of the impact of some of the work that they were done, not just on the farmers market side, but also on Produce Plus, has been really, really incredible. And particularly as it sort of helps around senior hunger. I think a lot of people don't realize when we're talking about farmers markets, we are talking about it from the clientele is not just young, recent college graduates going up to DuPont Circle to buy fresh produce, but it's actually quite a bit of seniors who are also using these programs. And in fact, when we look at it, I think for Produce Plus in particular, they have like 3,800 people on their wait list. So we're still not even meeting 100% of this. We're still not even meeting 100% of the need. But we're also seeing like increase on the seniors farmers market nutrition program and some of these other types of things. What do you think that's saying about the stability for our senior community when it comes to food access, that these programs are so popular?
Yeah, I think that as I mentioned in my testimony, I think that one of the things that the Produce Plus program really demonstrates is that when individuals have purchasing power, they're able to exercise their preferences and choice. I also know through the DC Health Nutrition and Physical Fitness Bureau that the Commodity Supplemental Food Program has increasing subscription every year from more and more seniors. So even though the rates appear to be at 100% each year, that's actually because they're adding additional spots. So I think that seniors are they're a prime population to take advantage of some of the public benefit programs, and an opportunity for the city, I think, to think about novel and market-driven ways that can actually not only just address hunger, but also advance some of our other like food resiliency and sustainability and regional economy priorities.
Okay. We'll definitely dig into that more. I mean, I want to give a shout out to DC Health, specifically the CHA administration, in terms of the work that they have been doing, and the programs are having impact, and they're making, they notice the dips and they have been addressing them. So, I mean, even from, we've increased our participation in WIC, which was something we challenged them on as we've been moving to EWIC, and increasing the number of stores who are part of the program. We've increased participation at Healthy Corners program and got more stores. So when we put more funding into these food access programs, money is not just sitting. People are most certainly using them. And so I think these are always good investments in sort of taking care of residents. But thank you so much for your testimony and for being here. I need to go faster. Okay, so Ms. Binney and Ms. Yamaguchi, thank you so much for your testimony. Ms. Binney, I'm concerned that you haven't received a response in your FOIA request. Have you received an update recently?
I did reach out last week, and they said they recently pulled all emails from recent decades and are currently looking through them. And so hopefully more will come soon.
Okay. And I appreciate the perspective, Ms. Yamaguchi, that you have, especially as a 14-year volunteer of HRA. And so, like I said to the previous panel, we've been having ongoing conversations about animal control and care. And we will continue to do so, and also bring this up, of course, next week with DC Health. And Ms. Lockridge, thank you so much for being here. I'm not sure if everybody knows that DC Health is about to move, but DC Health is moving from North Capitol Street over. And we can certainly ask them some more questions around what their changes in community engagement will look like now that they're sort of moving into a different part of the city that also is a part of the city that has some very unique health challenges and things like that. This is like part of my peppering in, so that the agency doesn't think that we just ask them all of these pre-hearing questions and that nobody reads them. But the leading cause of death in the district is heart disease. And that is tied to so many other things, and especially some of the issues that you've raised, whether it be access to food, access to physical activity space, air quality, all of these different things. And so it would be really interesting to see, obviously DC Health has to care about the entire city, but some specific focus and emphasis on now their new neighbors, to help try to bring down some of the rates that we are seeing. For those who are interested, in 2021, the leading cause was heart disease, second to cancer, and then the third was unintentional injuries, which includes drug overdoses. The fourth was COVID-19, and then the fifth was stroke. So a lot of these are health related, not other things that I think we definitely need to work on there. So I want to thank all of the witnesses on this panel for testifying. If you haven't submitted your written testimony for the record, please go online to the DC Council website and do so. But we're going to go on to the next panel. But thank you all for being here.
Thank you.
All right. The next 8, Rebecca Kahn, Kristen Ewing, Elizabeth Davis, Julie Krieger, Kimberly Brooks, Brenda Lee Richardson, Kate Finman, and Sabrina Rhodes. Okay, I see Rebecca. So Rebecca, why don't you go ahead and get started?
Okay, thank you. Is my volume working okay?
Yes, we can hear you just fine.
Great, thanks. Good morning, Chairperson Henderson and members of the Health Committee. I am Rebecca Kahn, the Nutrition Services Director at Food and Friends, and I'd like to begin by thanking you for your continued support of our mission to improve the lives and health of DC residents living with serious illnesses, such as ones you were just mentioning, like cancer, kidney failure, HIV/AIDS, and others that limit their ability to provide their own nourishment. Your support, as well as your time and your staff that you and your staff have spent volunteering with us, shows your neighbors your commitment to their well-being. We are also grateful for our partnership with Dr. Bennett and the staff of DC Health. You all helped us provide over 841,000 medically tailored meals free of charge to more than 1,900 district residents last year. Food and Friends is the only community-based nonprofit organization in our region providing home-delivered medically tailored meals and medical nutrition therapy. Looking to the fiscal year 25 budget, we respectfully request level funding at $1,335,000 to our Community Health Administration grant to help us continue to care for DC residents and their dependents. We rely on philanthropy and healthcare partnerships in addition to public funds from federal, state, and local sources. We're committed to maintaining this diverse revenue stream, and support from CHA is a stamp of approval when seeking that other funding. Your investment in Food and Friends is a good value. For each dollar we receive from the district, we raise $3.50 from other sources. Over 46% of our meals in DC go to neighbors living in wards 7 and 8, addressing geographical, social determinants of health, such as access to healthcare and food security. Those living with complex health conditions like diabetes experience 50% fewer inpatient admissions and 70% fewer emergency department visits than similar patients not enrolled in a medically tailored meal program. In DC, that translates into a cost savings of $700 million, according to the American Diabetes Association report regarding the cost of diabetes care for the 48,000 adults in the district diagnosed with diabetes. National research estimates that if all US eligible patients received access to meals with the Food is Medicine Coalition accredited nutrition standards, such as ours, over 1.5 million hospitalizations annually could be avoided for a net cost savings of $13.6 billion. All that to say, our services save the district money and improve the health of our residents. Food and Friends also enthusiastically endorses the other budget requests from the Fair Food for All DC Coalition members, which is attached to my written testimony, which has already been submitted. And our complementary food access solutions are producing measurable results, targeting the root causes and fills gaps of need within our community. Thank you for trusting our partnership to help you improve the health of DC's most vulnerable residents. Thank you for your time today.
Thank you, Rebecca. Kristen?
Good morning, Chairperson Henderson and the Health Committee staff. Thank you for the opportunity to testify today at DOH's Oversight hearing. I've also submitted a more detailed written testimony. My name is Kristen Ewing, and I am Policy Counsel at the DC Appleseed Center for Law and Justice. DC Appleseed is a nonprofit, nonpartisan organization that aims to make the district a better place to live and work through litigation, teamwork, and advocacy. Much of my work at DC Appleseed focuses on health equity and working toward a more equitable, just, and thriving city for all district residents. My testimony today will emphasize the importance of sexual health education, data sharing, and syringe access programs in addressing HIV, as well as the need to dedicate resources to reducing the health impacts of climate change. The HIV epidemic has long been a focus for DC Appleseed, and we remain concerned about health equity and the disparities we see in the district. In 2020, DC Health adopted a 95-95-95 plan focused on tackling the HIV epidemic in the district. This plan aims for 95% of HIV-positive district residents to know their status, 95% diagnosed with HIV to be in treatment, and 95% of those currently in treatment to achieve viral suppression by 2030. However, the district is not currently on track to reach 2 of these 3 goals. DC Health must focus on the following critical issues to reach their goals. We need robust and timely data sharing to address HIV. DC Appleseed urges DC Health to publish citywide HIV data more routinely and promptly to ensure providers and advocates can adequately respond and adjust to health issues in real time. In recent years, it has taken HOSTA more than a year to publish relevant HIV data, even though providers must report suspected or confirmed cases within 48 hours. HOSTA's most recent EPI report was released February 6, 2023, and the most recent data is from 2021. We have seen that DC Health can provide real-time data under certain circumstances like COVID and gunshot data, and we ask DC Health to prioritize distributing data more quickly, ideally through a public dashboard. We also need to ensure sexual education and increasing the Healthy Schools Act. These are crucial. We urge DC Health to work with OSSI to ensure all district schools are offering proper STI and HIV education as the Healthy Schools Act requires. As we have seen through the recent risk behavior survey, DC youth at both the middle and high school levels report steadily declining rates of condom usage as well as declining rates of HIV testing. So we need to make sure that OSSI is ensuring that we follow the Healthy Schools Act and that they have open dialogue with DC Health so that young adults are receiving the proper education. We also know that syringe access programs and opioid abatement are an important part of addressing HIV. We know funding for DC syringe access programs moved to DC Health, from DC Health to DBH, but we know that Dr. Bennett will be on the Opioid Abatement Advisory Commission, and we encourage DC Health to use its seat on the commission to emphasize the critical role that syringe access programs play in reducing new occurrences of HIV. Aside from HIV, we also want to lastly touch on an issue becoming increasingly relevant to the district, the inequitable health impacts of climate change. As a city, we are now witnessing the effects of climate change through issues such as increased temperatures, poor air quality, and intense storms. Based on studies conducted in other jurisdictions and the district's demographics, we can expect disparate impacts on neighborhoods east of the river. DC Health must commit resources to address climate change's ongoing and intensifying outcomes and their effects on health equity. We recommend that DC join 18 states and the federal government in creating an Office of Climate Change and Health Equity, a public health office dedicated to reducing the health impacts of climate change. Thank you again, and I'm happy to answer any questions you may have.
Thank you. Ms. Davis?
Good morning, Chairperson Henderson and members of the committee. My name is Elizabeth Davis, and I am the Government Affairs Manager at Children's National Hospital. Thank you for the opportunity to provide testimony at DC Health FY 23-24 Performance Oversight Hearing. At Children's National, we are proud to partner with DC Health on several community health improvement initiatives, such as our asthma program, Impact DC, and our child and family nutrition services through WIC. Today, I will focus my testimony on our school-based health efforts. You will later hear from Dr. Kruger on our work within our 2 school-based health centers that we operate, and Dr. Kimberly Brooks on the implementation of the Healthy Steps program at Children's National. As schools began to plan for the 2023-2024 school year, Children's School Services and Children's National partnered with schools and DC Health to ensure the health and safety of students by operating community health fairs throughout the city during the spring, summer, and fall. These health fairs allowed us to reach children and families over the course of 10 weekends. Through the Children's National Mobile Unit, we delivered over 1,300 vaccines to help children stay up to date on their immunizations. In addition, through partnership with DC Health, Children's School Services launched a new staffing model using a team-based approach. This model groups schools within their geographic proximity into clusters of 4 and assigns dedicated staff that include 2 nurses and 3 health technicians. With this model, the nurses in the cluster provide clinical care for medically fragile students, and the health technicians support nurses in documentation, medication administration, first aid, hearing, and vision screening, and serve as immunization points of contact for the school. Additionally, this model is important to focus on our limited resources where they are most needed to address the health inequities in DC. As we mentioned in our previous testimony at this month's roundtable, Children's School Services has continued to work with DC Health to provide coverage of the school health suites. However, Children's National continues to experience significant funding challenges with the school health services budget due to overall budget reductions year to year. This year, the decrease of funding and the addition of 10 additional health suites created a challenge of implementing the full scope of the program, which required us to limit to only in-person suite coverage and some case management support.
As the committee prepares for the FY 2025 budget cycle, please consider that a continued commitment to addressing the health needs of students in schools can result in real improvements in health outcomes. We look forward to growing our collaboration with DC Health as well as with other district agencies as we recognize growing public health concerns around community violence, opioids, and substance abuse impacting our youth. We welcome the opportunity to work together with this committee and other public health stakeholders to help solve for these issues. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Dr. Kruger?
Good morning, Chairperson Henderson and members of the committee. My name is Julie Kruger. I'm a community pediatrician and the medical director for the 2 school-based health centers that we run at Dunbar and Ballou High School. Thank you for allowing us to speak today at the performance oversight hearing. I am going to personally highlight the work with our department that works in the school-based health centers. At Children's National, the physicians, nurse practitioners, and psychologists in our Goldberg Center community-based primary care practices see over 100,000 visits annually. Over the past 8 years, we've received funding from DC Health to operate 2 of the 7 school-based health centers, and we're pleased to continue this work at Dunbar and Ballou. We truly thank DC Health for their continued support and partnership that enable us to provide this comprehensive adolescent-focused medical care. This includes preventive health visits, annual physicals, sports physicals, sick visits, childhood vaccinations, reproductive health services, dental services, mental health services, and health and nutrition education to the teens in these schools. Through the school-based health centers, we've been able to provide healthcare that is much more accessible, affordable, and confidential to the members of the schools. Our strong partnership with Children's School Services has also allowed us to ensure the health of the entire school community, and working very collaboratively with the school nursing team has been a strong commitment of ours this past year. Since beginning our school-based health center services in 2016, we've provided more than 7,000 patient visits. Focused on the last year, we served around 631 students, which was 338 at Ballou and 293 at Dunbar. We feel we continue to be a trusted resource for these students, and many of them have come back to us for further assistance. This is demonstrated in the fact that these 631 students had over 1,200 visits in our clinics in the past school year. Additionally, we were instrumental in getting students up to date with immunizations at both Dunbar and Ballou. In the last school year, our school-based health center providers gave over 400 immunizations, and just this past fall, we gave 100 additional vaccinations to the students that were overdue and would otherwise have had to go home and not stay in the classroom. We also partnered with the Children's National Mobile Units to help coordinate community events to support the district's vaccine efforts. 2 focuses where we continue to strengthen our work is in the area of oral and reproductive health. Last year, we recognized that there was a need to increase dental assessments, and this year we worked to educate our primary care team how to help do these oral health assessments and then appropriately refer to dental teams in the community for further care. In addition, we've expanded our reproductive health services and education by incorporating a reproductive health specialist with our team, who is working closely with the school teams to educate students on important adolescent health topics. We are truly proud of all the work we've been able to accomplish this past year. We thank DC Health for their continued support at the school-based health centers, and it is only with the support that we can provide the expertise of Children's National physicians to be accessible in the school. We look forward to the continued collaboration to serve our youth. Thank you for this opportunity to testify.
Thank you. Kimberly Brooks?
Good morning, Chairperson Henderson and members of the committee. My name is Dr. Kimberly Brooks, and I'm the program lead for the Healthy Steps program at Children's National Hospital and part of the Early Childhood Innovation Network. Thank you for the opportunity to provide testimony at the DC Department of Health fiscal year 2023 and 2024 performance oversight hearing. Today, I would like to highlight the importance of the Healthy Steps program and the impact it's had on DC families during the past fiscal year. At Children's National, we are proud to partner with DC Health on the implementation of our Healthy Steps program. With partial funding from DC Health and support from the Early Childhood Innovation Network and Children's National, Healthy Steps has continued to provide support to parents and families on issues such as feeding, sleep, attachment, caregiver depression, and community resource navigation. Healthy Steps also engages families through a Parent Advisory Council, or PAC, which provides families the opportunity to guide our Healthy Steps programming through suggestions and feedback. We are pleased to highlight that our PAC parents recently provided important feedback on a proposed innovation out of Harvard University Medical School called Small Moments, Big Impacts. This innovation provides Healthy Steps specialists with an opportunity to share videos with caregivers that relate to common parenting concerns, facilitating important discussions, and building strong parent-professional relationships. During fiscal year 2023, Children's National enrolled 392 new families. 777 children were screened, and 568 mothers were screened for postpartum depression. Our data and feedback surveys suggest that more children in the previous year than in the previous year are being identified and connected to early intervention services. More parents and caregivers are being identified and treated for mental health concerns, and families are connected to community-based services at higher rates due to Healthy Steps in DC. Additionally, with the success of our 2 Healthy Steps sites, Children's National secured funding last year to expand into a 3rd site in Columbia Heights. This expansion allows us to support families in another under-resourced area of the city with a high Latino population. Recently, the Healthy Steps research team conducted a qualitative study to better understand the impact of Healthy Steps from the point of view of providers and families. The qualitative study found that what is most valued by clinic staff is the Healthy Steps specialist qualifications for treating postpartum depression. What is most appreciated by parents is the Healthy Steps team members' ability to create a space where parents feel safe and validated. Healthy Steps' ability to address perinatal mental health bridges an important gap in care for this population and increases access to services for the most common complication of pregnancy, 2 priorities highlighted in the recently released report and recommendation of the DC Perinatal Mental Health Task Force. We commend DC Health on its commitment and investment in young children and their families, especially through its effective implementation of the Healthy Steps program. As Healthy Steps expands in the district, we will be able to reach even more families. Thank you for this opportunity to testify, and I'm happy to answer any questions you may have.
Thank you. Ms. Richardson?
Good day, Madam Chair Henderson. My name is Brenda Lee Richardson. I'm a Ward 8 resident and coordinator of APAC, the Anacostia Parks and Community Collaborative. The climate crisis is a health crisis. We hear that all the time, but what does it mean? Here in the district, it means more frequent and intense heat waves are increasing heat-related illnesses and deaths. It means more bad air days where it's hard to breathe. And it means more patients calling on our already strained public health systems. Combined with the ripple effects of the pandemic, disfavored communities experience higher levels of asthma, diabetes, high blood pressure, obesity, and are still struggling to recover. APAC is committed to working with the Department of Health to reduce the growing disparity in health outcomes and support a comprehensive community wellness approach. We applaud Dr. Bennett's recent appearance at Anacostia High School to roll out a new childhood vaccination program and are anticipating the opening of the Cedar Hill Medical Center early next year. But we are in need of more resources for climate resilience and adaptation, prevention measures, and educational services that would help keep more people mentally and physically well. We urgently need more medical professionals and patient advocates in our community assisting traumatized patients to navigate the complicated maze of healthcare to make sure they have access to a range of treatment options beyond prescription drugs. There is also a tremendous opportunity to address community wellness through environmental intervention. Park prescription programs are a wonderful example of how nature and good health are interconnected, and spending more time in natural areas, whether biking on local trails or relaxing in a park, is a cost-efficient way to improve physical and mental health. There is something so gratifying and healing about being outdoors, hearing birds sing, and being among the trees. I hope you will continue to support green infrastructure projects like Shepherd Branch and Suitland Parkway trails, which enjoy widespread popularity and would benefit the well-being of residents walking those trails. In closing, I would like to invite you and Dr. Bennett, the Director of the Health Department, to participate in a forest bathing activity in Oxen Run so you can see what we're talking about. It will change your life. Thank you.
Thank you. Kate?
Yes, thank you. I appreciate the opportunity to speak today about DC Health's oversight on the animal care and control contract. My name is Kate Finman, and I'm a volunteer at the Humane Rescue Alliance, also known as HRA, and a member of Volunteers for HRA Reform. Before I begin, I want to state on the record that I hope not to be banned from volunteering for participating here today. HRA has a history of retaliating against volunteers for raising concerns, but I'm still speaking because there is a desperate need for DC Health's oversight and intervention on animal services. I'm going to use my time to focus on the currently limited intake options for both dogs and cats, an issue that DC Health must take into consideration with the upcoming contract renewal. For dogs, the current contractor's protocols require owners to make a surrender appointment many months in advance, which isn't realistic given the often urgent circumstances that require surrenders. Even more devastatingly, HRA often refuses to accept surrendered dogs at all if they have shown even minor behavior or medical issues, unless the owners agree to surrender them as owner-requested euthanasias, which is a cruel and impossible choice to put on someone. There are many cases of dogs who are abandoned outside or even released at large because HRA turned their owners away or made them wait too long. Obviously, this is dangerous for the dogs, but it is also hazardous for DC families and their resident pets to have dogs running around loosely. DC residents need a well-defined, specific animal control contract that requires its contractor to accept all surrenders in a timely way and do what is best for the animal and for DC. For cats, the situation is even more dire. Under HRA's current policy, it will not accept any cats found outdoors because HRA says the cat likely has a food source. Cats living outdoors have more to worry about than just food, including cars, predators, human cruelty, and diseases. With this policy, loved indoor cats who escape outside have even less of a chance of finding their ways back to their families. HRA itself helped fund a study of outdoor cats in DC published last year that found that having cats outdoors is detrimental for the animals and detrimental to the environment because of the spread of zoonotic diseases. Yet the current contractor's trap neuter return program, if you could even call it that, is severely lacking. There are no spay neuter appointments are only available once per month, and DC residents must trap and bring in the animals themselves without guidance or assistance. As the agency tasked with overseeing disease management and spay-neuter initiatives, DC Health must take this seriously and ensure DC residents have resources and that cats who are candidates for indoor living have that opportunity. DC Health has a responsibility to the public to ensure DC residents have access to a well-run animal shelter and services. When the current contract expires, we need a better contract with clear definitions, more specific metrics, and robust reporting requirements to ensure that DC Health and the DC government have every oversight ability and enforcement capability necessary. Thank you.
Thank you. And last person on this panel, Ms. Rhodes.
Yes, good morning, Chairperson Henderson, staff, and all the witnesses here today. My name is Sabrina Rhodes, and I'm a community organizer with Empower DC, Resident Ward 5, Ivy City, and also ANC Commissioner 5DO2. And I'm testifying on behalf of Empower DC. The cost of public health is great because of environmental injustice and racism. And there are a lot of strange and strong chemical smells in our air, in our community of Ivy City. Ivy City is a sacrifice zone with industrial land uses and a chemical facility that emits toxic substances with no environmental protection, where our health and human rights are being violated daily. Residents are vulnerable because of the negative impacts of these toxic substances and pollutants we have no control of. Environmental injustice and racism are two of the most pressing public health issues facing our community and country today. They are closely linked, and they both have a devastating impact on the health of communities of color, such as Ivy City and Brentwood. Deterioration of physical and mental health, stress, anxiety, depression, fear, hopelessness, disease and disorders, respiratory infections, cardiovascular problems, birth defects, and cancer are the effects of air pollution, possible water and soil contamination with no healthy ecosystem to thrive on. There's little to no support from district agencies because of the lack of funding and resources. No regulations being enforced, if any, or regulations, if any, that are or that should be able to cover chemical facilities such as the National Engineering Products here in Ivy City that uses chemicals that are cancer causing. We also have engine idling from district agencies, and we just don't have the laws or the regulations to enforce or cover overburdened communities such as Ivy City and Brentwood. Working with the Office of Planning, we as a community, along with Empower DC, we're working closely with the Office of Planning to structure this small area plan here. And we also working with the Office of Planning with for the Northeast Avenue Vision Framework. We have current existing environmental issues, and there's a danger of any new construction and excavation, which can stir up toxic soil and possible lead from these old warehouses and buildings. My colleague, Anthony David, he also mentioned W Street, the RC bus terminal. The Department of Health will need to address this issue of making sure there's funding in the budget for DOH contractors to work with the Office of Planning and the Ivy City community and help identify any negative health issues and causes before, during, and after any development. That health assessments are included along with recommendations in the Ivy City Small Area Plan. Let me see, how much time do I have?
You're a little over your time already.
I'm sorry. You want me to wrap up?
Yes, please.
I can. We do appreciate your supporting the Environmental Justice Amendment Act of 2023. And we just want to know how the Department of Health will be committed to being a responsible agency and helping to protect the lives of residents in the district and help rid environmental injustices in our communities. We know that systemic racism, lack of resources, and negative historical practices are deliberate. Environmental racism, unequitable zoning, and redlining are the reason we are talking about this stuff today. And that the past, these things that happened in the past should have been left there, but they're not. And we are dealing and living with the results of these practices right now. I want to thank you for allowing me to testify and welcome any questions.
Great. Thank you so much for your testimony. Your colleague Anthony also presented great testimony earlier. I want to thank everyone on this panel. I do have a few follow-up questions. Dr. Kruger, I want to start with you. We were actually just looking at the data that DC Health sent us yesterday about utilization at the school-based health centers. And it's interesting that you have Dunbar and Ballou because we noticed in terms of utilization, those two campuses have less utilization than the other comprehensive high schools. And so I'm curious, even there were no oral health visits for Dunbar. There were, less sexual health visits at Ballou than all of the other schools. are we marketing the services available at these two campuses different than perhaps the others in terms of students not necessarily knowing what's available to them there?
That's a good question. I can't speak exactly to how the other schools kind of market. I would love to sit down with some of the other leads and kind of talk through that a little bit. I took over Dunbar and Ballou just in this past year, and we've been trying to increase our ability to reach out to the students. We've started going into, well, actually in the next month, we're going to be meeting every single student in their health class and helping them understand what services we have. And so the schools, especially Ballou and now a new team member at Dunbar, are really willing to let us get in there and meet every student. I think that one of the issues has been at the beginning of the year, getting the enrollment up at the schools and kind of getting those numbers and being able to do the outreach has always been a challenge. And we've been trying to sit in on more, back to school days and things like that. So it's, it's definitely good feedback for me to hear that those numbers are lower, and we are going to continue to work on increasing that enrollment by reaching out to the students. I think that it's one thing we as Children's National have tried to not tell the students they have to be enrolled, right? We want them to continue with their primary care team that they may have been with their whole lives, but then are welcome to join and be part of the school-based health centers if they choose to. So that's always been a fine balance that we've been trying to walk. But I definitely plan to continue to work on increasing that enrollment.
Okay. Is Ballou and Dunbar the only, Ballou and Dunbar the only two schools that Children's National is
correct?
Okay. Yep. I would definitely suggest that you all take or reach out to the other schools. If the number, let's say, the numbers were noticeably different. That's why I'm asking the question, especially when I think about from knowing the enrollment sizes of some of the schools, like a comparable size school enrollment was seeing almost double the number of visits that you all had. And so just kind of figuring out, is there something different about the school cultures of those schools? Are the the staff of the school-based health centers doing some of the work that you talked about, Dr. Kruger, of like talking to the health folks and making their selves more known? And then also, what are some of the services offerings, for instance, like Cardozo and Woodson and Coolidge have the highest numbers of mental health and behavioral health visits. And I don't know if, those leads have a different type of partnership in terms of the staff that they're bringing in to specifically address those needs for that student population. And so just something for us to focus on and to look at, just to make sure that all of our students know about all the various services that are available to them and can get to there. But thank you for being here. Ms. Khan, if you're still here with us. So I have a question that might seem a little unique, maybe not. To your knowledge, do we have particular nutrition standards in our shelter system as we're sort of dealing with people who might be unhoused but also medically fragile? And I was sort of thinking about, my team and I, we've volunteered several times at Food and Friends, and so I know like the diets that you all put together are very specific, right? If you're diabetic or renal or kidney or, other things. And it, to me, at least from some of the, recent reports that we have seen about some of the nutritional standards in some of our facilities, it doesn't seem like we're doing that same type of differentiation for someone who might be a diabetic, but also housed.
Sure, thanks. That's a great question. Is a unique question. So I can speak to what we do. I don't have any oversight over, obviously, the food that other programs in the city, whether it's shelters or other programs, provide. But if there are people that referred to our program and they're unhoused and either staying in a shelter or not, we talk to them about what their resources are. And we actually have a shelf-stable meal plan that's fairly customizable based on somebody's living situation, and we can change it. You know, that's part of the benefit also of having the team of dietitians and, you know, having those one-on-one relationships. Yesterday, I just changed somebody to kind of a specific, still low sodium, heart healthy meal plan, but they don't have access to a microwave regularly. They can sometimes access a fridge, so we'll create a specific bag for them. So I can speak to what we do, and unfortunately, I can't speak to what happens at other agencies.
Right.
Does that answer the question?
That it did sort of. It's
Okay.
an area that I'm going to have to probably follow up with DHS on a little bit more.
Sure.
But I think it's a question not just for someone who might be unhoused, but in some of our other populations as well. There was a recent news report about the Harriet Tubman shelter, women's shelter in Hill East. And, you know, if we have a shelter situation where we have a lot of individuals who are seniors who are facing things like hypertension, heart disease, diabetes, et cetera, we should probably tailor the meals so that we are not adding to the deterioration of their health condition simply because they aren't able to afford a healthy meal. So that's definitely something for us to think about going forward. Ms. Ewing, thank you so much for your testimony. We have let's see. We share your concern and desire for more regular updated data on a variety of different topics. And we've communicated this to DC Health. At least I have had a feeling, and I'm sure probably the outside groups are also feeling this too, is that the pandemic hit and literally all of our data reporting basically stopped on anything that wasn't COVID. And as a result, as we're now trying to catch up on some things, we're seeing upticks on HIV, STD, all of these other pieces. And so we're going to check in on some of that. We've gotten some updated data and the pre-hearing questions. So I welcome you to check some of that out. But can you say more about the dashboard that you would like to see?
Yeah, so I think what we saw during the pandemic, as you're mentioning, everything was COVID, and we were able to implement this kind of routine weekly, monthly data dump happening. And we need that for things like HIV. Like I said, we're working off of 2021 data right now. So we don't know when there's maybe hotspots, certain populations we should be catering towards, with education, with treatment, and how do we know how to respond if we're not getting, current data? Right now, current would be 2022, but I think real time allows advocates and providers to really respond in a way that is actually effective instead of seeing what happened 2 years ago and then wondering, okay, should we respond that way or is that not even relevant anymore? So I think looking at how we approach COVID, trying to do the same kind of thing with public data on a public database.
I think that is incredibly important. I did bring that up in December when we were talking at our maternal health hearing, because the information or the anecdotes I was getting from the hospitals is very different from the data for which I think we only had 2018 data on maternal health. And so our hospitals were seeing an uptick in issues and complications with substance use disorder in some of our pregnant women. And if I don't find that out until 2025, we've missed the window. And so how can we put out more timely data is something that we're definitely working on. And so we'll raise as well. And to your point around the syringe access programs, I'll just note for folks that on the other side of Pennsylvania Avenue, they have are debating an appropriations bill that would essentially stop DC from, again, doing needle exchange, which is bewildering to me because we have data. We have the reports that shows the last time they stopped us from doing needle exchange, what happened. And so, hopefully Democrats on the Hill can strip that from that legislation there. But I'm well over my time. I don't have any other further questions for the folks on this panel. I want to thank you again for your testimony and for being here. And if you haven't submitted your testimony for the record, please go online and upload that now. We are going to take a really quick 5-minute break, and then we'll go on to our we'll finish up, and so we'll bring on the next panel. I'm so sorry, guys, but we've been sitting here for 2 hours, and so or a little bit more than 2 hours, and so we'll be back in 5 minutes. Thank you. Okay, and we are back. So to get to the next 8, I think you guys are already in the room. So Hugo, when you're ready.
Can you hear me?
Yes.
Thank you. Good morning, Councilmember Christina Henderson. Thank you for this opportunity to testify. My name is Hugo Mogolan. I am the Executive Director at Fresh Farm. The organization is deeply committed to fostering a healthier and more equitable food system. Today, I'm honored to speak about the transformative effect of our collaboration with DC Health through the Produce Plus program. Produce Plus distinguishes itself nationally as a pioneering initiative of the District of Columbia's government. Its impact extends beyond food distribution. It represents a strategic investment to improve the health of groups most vulnerable to food insecurity and diet-related diseases, such as Black and Latino households, families with children, and senior citizens. In 2023, our partnership with the city helped 5,445 enrolled DC residents purchase over $900,000 in fresh fruits and vegetables. More than 4,000 of these individuals were seniors, a 10% increase from the previous year, underscoring both the escalating need among this demographic and the program's effectiveness in reaching them. Additionally, over 60% of program participants are residents of wards 5, 7, and 8, areas that starkly represent or see disparities in food access and a legacy of systemic inequities impacting communities of color. Our partnership with DC Health has provided essential nutritional support and generated critical data to inform the city's decision in utilizing food as medicine. An overwhelming number of our participants are Medicaid recipients, with significant numbers reporting conditions like hypertension, diabetes, and high cholesterol. The positive impact of a Produce Plus is evident. In a recent survey of over 1,400 participants, 98% reported an increase in fruits and vegetables consumption, 96% felt healthier, and 93% gained valuable knowledge about healthy eating habits. These figures are not mere numbers. They represent real people and real families making tangible, positive changes in their lives. However, the demand for this program is greater than our current funding. Last year, 3,800 individuals remain in our wait list, signaling an urgent program expansion to meet this unmet need. The role of the staff at DC Health in these achievements cannot be overstated. Their leadership, commitment, and permanent support in helping us navigate challenges have been pivotal to making this a citywide success. I thank you for your attention and for considering the substantial impact of this program. Together, we can continue to make a meaningful difference in the lives of our community members. Thank you so much.
Thank you. Ms. Nay?
Thank you, Chairwoman Henderson, for the opportunity to testify. My name is Dr. Chipi Nian. I'm an epidemiologist and a Ward 5 resident. I volunteered with the Humane Rescue Alliance, HRA, for 8 years until December 2023. I'm a member of Volunteers for HRA Reform. I'm here today to call your attention to HRA's inability to control disease outbreaks in the DC animal shelter. Since infected animals could be contagious prior to the development of symptoms, it is a public health issue that affects the DC community and puts DC pets at risk. Starting October 2022, there have been cases of canine upper respiratory infection, URI, lingering in the shelter. During that time, the medical staff admitted that they were dealing with a very tricky URI strain. However, no specific disease management protocol was developed. URI dogs were housed next to healthy dogs, and the policy of the use of personal protective equipment, PPE, was not enforced. In March 2023, while continuing to battle the URI issue, HRA had a parvovirus outbreak. A few days later, HRA transferred in more puppies from South Carolina. This demonstrated HRA's lax attitude towards disease control and also showed how HRA was not prioritizing DC animals. In August 2023, HRA had a canine influenza outbreak, followed by another parvovirus outbreak within 3 weeks. Again, HRA struggled to develop a well-designed disease management protocol. Healthy and sick dogs continue to be housed next to one another. PPE was required. However, there were no clear instructions on how to properly put on or remove PPEs. The series of disease outbreaks put more stress and extra workload on staff, resulting in animals living in inhuman conditions, suffering from medication mix-ups, and experiencing limited human interaction and enrichment, etc., which all lead to a higher chance of euthanasia. HRA's failure of disease control poses a public health risk. Without a disease management protocol in place, HRA may have adopted out infected animals only to become sick a few days later in their new home. Also, any potential adopters visiting the shelter can easily be exposed to contaminated environments and then spread the pathogens to the DC community. As a pet guardian, DC resident, and epidemiologist, I urge the committee and the DC Council to keep HRA's poor disease management in mind when reviewing the new contract in July. I urge you to please strengthen the terms in the future contract to hold HRA accountable and help prevent infections to keep the DC community safe. Thank you for your time.
Thank you. Cammie Knox.
Yes, ma'am. Good morning. My name is Cammie Knox, and I'm a consumer and a donor of the Humane Rescue Alliance. I am testifying here today to voice my concerns over the current contracting and oversight of the services that are needed from HRA. On January 11th, 2024, I wrote a letter to the Board of Humane Rescue Alliance DC regarding the increasing concerns over the dogs in their care, their transparency in their behavioral work, and the treatment of their volunteers. I share this letter in hopes that it will be heard and taken with the sincere admiration I have for the volunteers and paid caregivers. The job of animal welfare is difficult and similar to my 25-year career in law enforcement, in that we see the worst in people. Though animal control circumstances, they are seeing the worst towards the most defenseless of victims consistently. These concerns I have seem to ultimately rest with the decisions being made by those in management and the lack of apparent oversight to the contract the District of Columbia has with the Humane Rescue Alliance. I also have concerns regarding the financial choices HRA has made with fewer caregivers and certified behavioral trainers, and a CEO's salary at least double, very nearly triple, those of other equivalent positions within the region. I recently had the opportunity to speak to a board member of another jurisdiction's contracted animal welfare services shelter and learned that HRA's overcrowding, resistance to supporting the adoption of their dogs through other regional shelters, and the welfare and handling of these dogs has become the subject of conversation. Obviously, these conversations are not showing HRA in any type of positive light. When other shelters offer to accept adoptable dogs from HRA to allow HRA to reduce their occupancy, HRA responded by offering only the dogs that they had labeled aggressive and unadoptable, leaving the impression they are more concerned with offloading dogs they do not care to work with, rather than helping to place their clients, those dogs, into safe and healthy environments. The irony that most of these dogs were labeled as such is only a reaction by the dogs to the environment they have been kept in within HRA facilities for weeks and months is not lost on those faced with HRA's rejection of their offer of help. The storage of dogs in travel crates in warehouses is not an acceptable standard of care and should not be allowed to continue. I ask that the District of Columbia take the responsibility of oversight for the contracts and laws binding HRA to their work and hold them accountable. HRA is clearly not adhering to contracted services, and DC appears content to accept the least amount of work and quality possible. DC needs to demand more. You need to hold HRA accountable to the highest standards of animal welfare services and accept nothing less. Money needs to be more appropriately allocated to the services needed, the actual care and handling and training of the clients, the animals they are mandated to care for, must be better. DC needs to demand better. And the letter will be uploaded to the testimony.
Thank you. I don't see Mr. Black, but if he pops up, we'll certainly let him in. Mary Proctor.
Good morning, Chairperson Henderson and members of the committee. My name is Mary Proctor, and I am a member of Capitol Hill Senior Village, and also the 4 years member of the Workforce Development Subcommittee that you have already heard from. In this past December 18th, more than 70 members of DC Senior Villages gathered on Zoom to view a powerful presentation called Senior Village Town Hall. It included PowerPoint explanations of the increasing shortage of direct care workers, which include home health aides and certified nurse assistants. And you can see yourselves Senior Village Town Hall on YouTube. The title is Senior Village Town Hall. 7 videos allowed bedbound patients, family caregivers, and paid direct care workers to talk of their lives. It was poignant to listen to these stories. All of the patients were bedbound and helpless if home health workers did not come to care for them. They could not eat or drink or get to a bathroom. If they were lucky, a family member could take a few hours off work to help them. If they were not lucky and the family member could not take off from work, then the bedbound patient endured a whole day in bed, uncomfortable from a lack of food or water, or soiled while waiting to reach a toilet. The family members talked of the terrible choice between helping a loved one or carrying out their work duties. A home health aide talked of the impossible demands of challenging work and low pay that was very difficult to live on. Near the end of the presentation, people watching on Zoom were invited to comment. Many of them talked of caring for a spouse for many years without much help from home health aides, whether Medicaid or from private pay agencies. They talked about how difficult is the work of caring for a bedridden loved one. This talk made me fear my old age and that of my husband. I'm asking you to listen closely again to what Claudia Schlossberg and Veronica Sharp talked about, all the ways in which this situation could be improved. What you have included in the bill coming up for hearing in March, called Direct Care Workforce Bill. And later in this testimony, you will hear from Neil Richardson, who talks about the importance of interagency coordination within the Department of Health and also between the Department of Health and other agencies in DC. My overall point is that bedridden older people cannot testify in person and cannot wait several hours on Zoom for the moment to speak. The DC government should pay attention to what we hear from bedbound adults and make it clear that we do not ignore this disabled and elderly because we don't ever hear from them. Thank you very much for listening.
Thank you for your testimony. Rajan Thomas.
Good afternoon, Chairperson Henderson, members of the Committee on Health. Thank you for this opportunity to testify before this committee. My name is Rajan Thomas, as was mentioned, CFO of HMI Home Health Agency, and I'm current president of the DC Home Health Association. I represent one specific sector of the spectrum of health providers that partners with DC Health to assist in fulfilling its mission. And the home health provider's mission mirrors that of DC Health, with specific focus on promoting the health and wellness of vulnerable and aging residents within the comfort and security of their places of residence. And in accomplishing DC Health's mission, one of the stated strategic priorities of DC Health is to strengthen public-private partnerships. This partnership is what I would like to emphasize in the expectations that home health agencies have of DC Health. Furthermore, the public-private partnership needs to include all district agencies that need to work together to accomplish the mission of DC Health. And I would just, there is obviously no shortage of statistics that have been flowing regarding the shortage of trained direct care workers, which again, I understand, will be addressed again in your March hearing. I will just like to present a couple that have been repeated before. Until the number of home health aides returns to the required level, CNA should be permitted to work as HHAs. Replace the CEU and 8-hour work requirements with a brief refresher orientation session offered by employer provider agencies as part of the licensure reinstatement criteria. And give home health organizations permission to teach and assist in licensing personal care assistants. And I would say the most crucial change would be to eliminate the board exam for new PCAs. The level required is 8th grade, but the tests often are at a 12th grade level. Finally, in conclusion, I would say I recommend that DC Health take a lead in facilitating the partnership among all DC agencies, including healthcare finance, regular meetings with focus groups from the various health provider sectors would be beneficial in finding solutions to the challenges that we face. Thank you once again for this opportunity.
Thank you. Ms. Brown?
Good morning. Honorable Chairperson Henderson, my name is Jacint Brown, Chief Impact Officer at DC Central Kitchen. Since 1989, we have targeted the root causes of hunger with innovative programs that lower barriers to employment, create living wage jobs for district residents, and bring nutritious, dignified food where it is most needed. We are proud to partner with DC Health's Community Health Administration on the award-winning Healthy Corners program. For 12 years, this nationally acclaimed solution has taken on the deep-rooted challenges of food deserts by empowering local businesses to become robust, reliable access points for healthy, affordable food while working with customers to increase awareness of healthy options, build trust, and expand their purchasing power when making healthy choices. This committee is acutely familiar with the significant food access gaps that remain in our city and the impact those gaps have on rates of chronic disease. Because of the hard work of DC Health, this committee and the small business owners, DC residents, and DC Central Kitchen staff who make up the Healthy Corners community, we are doing more than ever to fill those gaps. Today, Healthy Corners is delivering fresh and frozen fruits and vegetables to 53 corner stores in DC and has sold more than 390,000 units in the past 12 months. Through partnerships with DC Health and the WIC State Agency, we have nearly quadrupled the number of WIC retailers in Wards 7 and 8 since 2021, with 11 Healthy Corner stores now accepting WIC. Since 2018, we have brought USDA funding to DC with matching support from DC Health that expands the purchasing power of more than 15,000 SNAP customers when they select fruits and vegetables at participating corner stores. Thanks to USDA's latest 4-year renewal of our innovative nutrition incentives called SNAP Match, DCCK has now secured $1.9 million in total federal funds for these incentives, every penny of which flows directly to DC SNAP customers and is redeemable only at small DC corner stores in food apartheid areas. That is a powerful win-win, a nationally acclaimed model that other cities are trying to emulate, and proof of a public-private partnership that is working for our residents. We hope when it comes time to discuss the FY25 budget, DC Health will maintain their support for this program and ensure this year's USDA funds are fully matched. Everywhere we turn, more DC residents have critical needs for food assistance, and if we don't get healthy food access right as a city, we will continue to pay the price in health outcomes, educational attainment, work readiness, and community cohesion. DCCK and our Healthy Corners partners are doing everything we can to help DC's food insecure SNAP customers make ends meet and meet their nutritional needs at this time of rising prices and economic hardship. But DCCK is just one nonprofit. DC is home to numerous homegrown food access solutions. DC Health deserves recognition for its efforts to align these various programs and access points from corner stores to farmers markets to produce prescriptions in ways that reduce silos and low barriers. We encourage the committee to continue to support continue its support of DC Health's portfolio of healthy food access solutions. We also applaud your ongoing commitment to the SNAP program. SNAP is a force multiplier for food providers like us, and recent investments in SNAP will help small corner stores step up and provide even more of the healthy options our residents deserve. We are grateful for DC Health's partnership and believe it is a model for this city and others. I'm happy to answer any questions that you may have. Thank you.
Thank you. And finally, Dr. Patel. But I don't see Dr. Patel here. So I want to thank all of the witnesses who testified on this panel. Mr. Mulligan, well, you and I met and we were able to chat more in depth in terms of the work that you all have been doing from Fresh Farm. It's kind of an interesting question necessarily to ask, but if you had more dollars, I guess I could ask the same thing of Ms. Brown as well for the work that they're doing in terms of DC Central Kitchen, et cetera. Like, is there a way for us to completely 100% meet the need of demand versus what programs we have slots for?
Okay, I'm gonna say that probably, I don't know, we could cover 100% of the need, but definitely right now, it seems like the need is too much, right? If our program Produce Plus is serving 4,500 people and our wait list is 3,800 people, so definitely seems like the need is way above our capacity. I feel like the city should decide to make these investments so we could realize what actually is the need, because right now probably is a question that we all have, right? Like with COVID and with inflation, several things seems like the need keeps rising. So the expectation that we have is like in some point these probably would stabilize, but unless we have the resources, we won't be able to know that what's actually the potential of our program. So we know that in the case of Produce Plus, with the technology and that we are using, we are able to quickly enroll people, so we would be able to reach the capacity in record time probably. So I think that
Okay.
that's, yeah.
All right. Ms. Brown, are there stores that would like to participate in SNAP Match but are on your waiting list?
Yeah, we are working with a couple of stores that are on the waiting list for a variety of reasons. Of course, they are going through the process of either firming up their POS systems, that's their point of sale systems, or we're going through the process of making sure that they are fully equipped in their refrigerated and freezer sections to make sure that they comply with the requirements of the Healthy Corners program and the SNAP Match program.
Okay. When I, visited with you guys, several of the stores that participate in the programs, one thing that came up was the need for, there are stores who certainly want to participate in the program, but they might find it cost prohibitive to sort of make the investment in the refrigeration areas and those kinds of things. Have you all thought more about how we could potentially address some of those issues and needs?
Yeah, absolutely. Our program does assist with refrigeration needs. To your first question about, would more funding bring us to 100%? Our goal always is to put ourselves out of business in hunger. All of us that are fighting hunger, we want to be out of business one day. The reality is that more funding reduces the gaps that we have in food access. So increasing that funding, of course, would help us to provide more refrigeration, beautification of our storefronts, beautification of our corner stores inside, increases likelihood of traffic, for our residents to participate in the programs. So yeah, refrigeration again is provided through our Healthy Corners program, but funding is always a concern and an issue.
Got it. Okay. All right. Well, I don't have any further questions for this panel. I've heard lots of testimony about HRA, as well as, for our senior population as well. Ms. Proctor, thank you so much for being here, for your particular testimony, especially about not losing the voices of those who might be bedridden, as we're thinking about some of these particular issues. And it's certainly something that's top of mind for me. So thank you again for this panel. And we're going to move on to the next group of 8. Will Doyle, Rochelle Ellison, Robert Warren, Mercedes James, Jakia Carroll, Neil Richardson, Nikki Smith, and Dean Brenner. Okay, we have folks who are coming in, but I see Will. So Will, why don't you go ahead and get started?
Thank you. Good afternoon. My name is Will Doyle, and I'm the Vice President of Housing First Pathways to Housing DC. We greatly appreciate your commitment in 2024 to ensure that our government is working efficiently, and your recognition that public input during oversight hearings is key to achieving that goal. DC Health requires that applicants for social work licensure pass an ASWB exam for each of its 4 license types. The ASWB released exam pass rate data in August 2022, showing incredible disparities in pass rates based on race, age, and language. During FY23, DC Health has failed to complete any substantive action to analyze the impact of the continued use of the ASWB exams or to engage DC social workers and agencies about it. This is despite having the past experience of licensing social workers while exempting them from the exam requirement. Had they analyzed this practice, we would have information crucial to assessing the use of ASWB exams. When I submitted the FOIA request for such information, DC Health responded that it does not routinely keep statistical information on such distinction and therefore does not have any information that would be responsive. In the face of significant new information, DC Health is intent on sticking to routine for routine's sake. This is not the type of leadership we need from our government agencies amidst a mental health crisis and severe shortage of social workers that actively harms DC residents. Instead of taking action, DC Health has continuously expressed confidence in the ASWB. After advocates attended the Board of Social Work meetings in September and October 2022, we were told that the ASWB exams would not be discussed further at their meetings, and the Board of Social Work issued a written response acknowledging the pass rate disparities and impact on the workforce. Deep concern was expressed, but all actions were directed at continuing their work as members of the ASWB. FOIA requests reveal that there are no formal documents or arrangements between the board and the ASWB. There is therefore no way for DC Health or this committee to judge whether the Board of Social Work is acting on behalf of the ASWB or DC. The chair of the Board of Social Work has had a pro-exam video on the ASWB's LinkedIn page since early 2023. The Board of Social Work gave the ASWB a platform to promote their exams at the March 2023 board meeting, while not substantially answering questions from the public. DC Health testified in opposition to the Social Work Licensure Modernization Amendment Act of 2023, by arguing that the exams are needed to ensure competence and public protection while not being able to provide evidence to back up these claims, further suggesting that their stance is based on a conflict of interest with the ASWB. A FOIA request requesting proof that passing the ASWB exams is correlated with competence, ethical practice of social work, and public protection resulted in the statement that the Department of Health does not have documents that would be responsive to your request. DC Health has ignored the continued significant harm on social workers impacted by the use of the ASWB exams. This includes exclusion from employment in the social work profession in DC, as DC Health considers it to be unlicensed social work when BSWs or MSWs work without licensure. This is particularly egregious since at the same time, DC Health is employing an unlicensed MSW as the executive director of health professional licensing boards. DC Health's position is compromised by a conflict of interest with the ASWB, a lack of evidence, and not adhering to their own standards. I urge you to pass the Social Work Licensure Modernization Amendment Act of 2023, despite your opposition. Thank you for holding this hearing.
Thank you. Rochelle?
Good afternoon, Councilmember Henderson and members of the Committee on Health and DC residents. My name is Rochelle Ellison. I'm the Assistant Director of member of People for Fairness Coalition, an organization of individuals with lived experience who do our best to give resources and in housing and stability through advocacy, peer mentoring, and outreach. I'm also a Medicaid recipient. Recently, I contracted COVID-19. When my doctor prescribed Paxlovid, CVS informed me that my insurance, Medicaid, was terminated. I was sick and now needed to advocate to beat COVID-19. I went to 2 different emergency rooms, but was treated differently because of my status of having no healthcare insurance. They tried to put me in the lobby with it. I was infected with people who were not. I announced this to all the waiting patients and left to come home. My doctors were doing virtual visits because I have SLE lupus, stage 2 emphysema, and I'm in early stages of heart failure. I would not have been able to fight COVID-19 without this medication that cost $1,600. So as bad as I felt, I had no choice but to advocate for my life. I emailed the DHS director and they put a case manager on my case to assist rapidly getting my AmeriHealth Curatis DC reactivated. I was able to get the medication on day 3 of having COVID. After day 5, I might not have been here testifying today. Thank God I'm an advocate and knew how to advocate for myself. I was told this was a glitch in the system. It was a glitch that should not have happened. What about those individuals that haven't found their voice that had this happen to them too? It's very serious to walk around today and not have healthcare services. Housing is healthcare. I could not self-care the way I do today when I was unhoused for 17 years, the way I can today being housed, keeping doctor's appointments, taking medications that manage the symptoms of my diseases that are keeping me baseline as healthy as possible with diseases that have no known cure. It is so important to understand that the individuals we serve are unhoused and literally dying in the streets. It's important to sign them up for healthcare, especially when they have so many different needs, to be in just survival mode until they get housed and have a stable footing to go to a different level of self-care without worrying about being sick and not covered under Medicaid. I also believe housing is a human right and Medicaid can pay for short-term housing until an individual gets matched to lease up. I will advocate for this and assist in any way I can. Thank you for this opportunity to testify. I'd be happy to answer any questions. Rochelle Ellison.
Thank you, Rochelle. Robert Warren.
Good afternoon, Chairperson Henderson, members of the Committee on Health, DC residents. My name is Robert Warren, a PFFC member and a longtime housing advocate for unhoused DC residents. With us being individuals with lived expertise, we at PFFC have identified 5 health issues related to the unhoused community we would like to touch on today. The first one being related to unhoused community, we would like to touch on it. The first one being the belief that for many of those in unhoused community, housing is healthcare. This year in the District of Columbia, there were 90 individuals who died without the dignity of a home from preventable health causes. A great majority of those over the age of 55 years of age on fixed incomes. Our healthcare system has to be integrated in order to identify individuals in the system living with inadequate housing placements or in low-barrier shelters for individuals over the age of 55 years of age. Lifelong DC residents or long-term DC residents to be guaranteed housing placements through their assistance of Medicaid, Medicare, and Social Security connected to extremely low-income housing subsidies. We as a city and the nation's capital can adequately identify housing resources for this age group of individuals. We will reduce the cost of hospital visits through 911 emergencies and other city services, which the budgets are affected dramatically by individuals that are unstably housed over the age of 55 and those uninsured with no health care coverage. For this population of people and all individuals in our low-barrier shelter system, there must be much better coordination between service providers and our local health and wellness service agencies and the providers for individuals in our shelter system, including those living in homeless encampments. We should be working to provide holistic health approaches to better service for these individuals living in communities of poverty. This marginalized community, we're hoping that the healthcare system can begin to offer more therapeutic sessions, incentives for those engaged in their own health recovery for us in the lived experience community. This also means better overall health literacy for community members to be aware of how to plan and engage in acquired health coverage and insurance for afterlife planning. We have a lot of people who die without the dignity of a home and can't even receive proper burials in the District of Columbia due to financial costs. We're asking for $1 million to helping families and communities to give a person a proper burial if they should die waiting to be housed. Lastly, but more importantly, helping individuals who qualify for Medicaid and Medicare and updating their information within the system so they are properly insured and able to take advantage of improving their healthcare experiences overall. Thank you so much for this opportunity to testify, and I will be happy to answer any questions.
Thank you. Mercedes James?
Hi, everyone. My name is Mercedes James. I'm the Associate Director of Health and Compliance here at KIT DC. We operate 21 school and programs across 8 campuses, and we serve 7,300 students. Unfortunately, DC's nurse attrition, along with the difficulty of hiring qualified health technicians, has often left 7 of our 8 campuses with less than 40 hours a week of the coverage that we need in the health suites. This is putting added pressure and stress on regular school staff with the administration of medicine or the AOM certification to administer medicine more often, having less confidence, preparation, and skill than the nurses. Some current challenges for the AOMs at KIT are we have about 20 out of 60 staff members who are AOM certified. Serving as an AOM so often impacts our regular job duties. There's strict timelines to access the training modules for the AOM certification, 9 burdensome things that we have to do or take in order to complete the training. There is also a requirement to travel to Silver Spring during the workday for an 8-hour training and back while also completing our regular work duties. I like to highlight 2 enduring challenges of the school nurse model. The health suites are still not equitably and consistently staffed, and we still have no clear description of the nurse and health tech responsibilities. However, I do also want to highlight one positive out of the nurse school model, and that is a stronger day-to-day communication between the nurse managers and the school leaders. And we know that the model challenges will not be fixed overnight. And we want to reiterate that we support and appreciate the creative new model that is attempting to provide all the students in DC with better access to healthcare while at school. Thank you.
Thank you. Jakia Carroll? Don't see. I don't see Neil Richardson or Nikki Smith, but I do see Dean Brenner. Dean?
Thank you, Chair Henderson. My name is Dean Brenner, and I live in Ward 3. I chair the board of the Alzheimer's Association's local chapter, and I'm the national treasurer. As a former caregiver for my mom who passed away from Alzheimer's, I care deeply about the 10,000 people in DC living with Alzheimer's and the over 14,000 family members taking care of them. Researchers recently found that if DC were a state, we'd have the highest percentage of people with Alzheimer's out of all states. We need more direct care workers, more geriatricians, more neurologists, and more support for people with Alzheimer's and their families. As you know, we've begun to make progress in addressing the DC Alzheimer's public health crisis, but there are 3 issues which I urge this committee and DC Health to address. First, all 50 states have an Alzheimer's plan, but as I testified last year, DC's plan expired in 2019. There's a draft plan, but to date, DC Health has not released a new plan. So this is our 5th year without a DC Alzheimer's plan. Now, I've read the pre-hearing responses, and over the past few years, we've established a good working relationship with DC Health. I know they've been stretched by COVID, and Dr. Bennett is now on board. I hope very much that DC Health soon releases a new Alzheimer's plan, circulates it widely, and that we can work together to implement the new plan. Second, in 2020, the council passed a law to require dementia training for all direct care workers, but the law hasn't been implemented. Again, I understand DC Health's challenges, and I'm hoping DC Health will fully implement this important law soon. Thousands of people living with Alzheimer's depend every day on direct care workers for so many aspects of daily living, nursing homes, assisted living, day programs, and at home. They need the training that the law requires. Finally, 2 years ago, the council approved $250,000 to raise public awareness in DC about Alzheimer's. To their credit, last year, for a few months, DC Health rolled out an extensive campaign, including ads on cable TV and buses, but the campaign only lasted for a short period of time. And with such a short campaign, many people in DC are still unaware of the services for people with Alzheimer's. Moreover, the FDA recently approved 2 drugs that meaningfully alter the course of the disease by addressing the underlying biology of Alzheimer's. But these drugs can only be taken by people in a very early stage of Alzheimer's or even have pre-Alzheimer's. So early diagnosis of Alzheimer's is now essential. A person with an early diagnosis may qualify for a drug, a person without an early diagnosis will not. So it's crucial to reach as many DC residents as possible to alert them to the signs of Alzheimer's so that those with an early enough stage can get a diagnosis and qualify for treatment. In sum, we need more funding for DC Health for two purposes: increasing public awareness of Alzheimer's and implementing, hopefully, a new updated DC Alzheimer's plan. I look forward to working with DC Health, with you and the rest of the council to obtain and use this funding so that DC can enter this new era of Alzheimer's, the era of treatment. Thank you very much.
Thank you. And thank you so much hold on. I see Neil now. Neil? You're on mute, Neil. Neil, I see your mouth moving, but you're on mute.
Hello, good afternoon. My name is Neil Richardson. I'm a Ward 1 resident, and I'm the Deputy Director at DC Appleseed. Today, though, I'm testifying in my capacity. Let me see if I can fix my camera. I'm testifying in my capacity as the acting coordinator of the DC Coalition of Long-Term Care. The coalition works to expand and improve the quality. The quality of long-term care programs and ensure that the district residents living on low incomes and with disabilities can age in the community safely and with dignity. So currently the district struggles with an inadequate number of long-term care beds and assisted living buildings, as well as inadequate number of providers offering care services in homes, which is where most of us are going to age throughout our lives. The shortage of long-term care services disparately impacts individuals who cannot afford to pay for care privately. Consistent and quality care should be provided to all, no matter where they live, what they look like, or their economic status. The coalition hopes that Dr. Bennett's leadership, DC Health, will be more transparent and data-driven, and that the agency will work in coordination with the district agencies that touch long-term care issues, especially the workforce shortage that Claudia Slotsberg, Veronica Sharp, Mary Proctor all spoke to and articulated it very well. I will spare you about going down on my concerns around workforce issues, because I think they said what needed to be said. But I do think this is a crisis, and maybe you don't, Councilmember Henderson. But for folks that don't have care on the weekends when it's really hard to bring people in, it does become a crisis. So I'm going to have one recommendation. I think that DC Health, in collaboration with Deputy Mayor Wayne Turnage, should form a working group bringing together and increasing collaboration between the multitude of district agencies that impact long-term care services. Now, in my testimony, I kind of draw up kind of an example of where all these different agencies touch and interact. I don't have time to go into that, but I would just want to emphasize that we really believe that DC Health, in collaboration with the deputy mayor, who has the authority to bring all the actors together, really need to begin meeting regularly. When I was in the Williams administration, in charge of the strategic planning process, we brought all the clusters across government together, not only at the high level for the deputy mayor level, but all the way down to the staff working on things at the street level and low level staff. That's what I'm sense is missing around long-term care issues. So thank you very much.
Thank you. Okay, so thank you again to this panel of witnesses for your testimony. Ms. Ellison, I wanted to start with you if you're still with us. Can you say a little bit? Okay, great. Can you say a little bit more about the glitch in the DHS system, if they explained it to you? So, we've last year we had several hearings around Medicaid renewals, and lots of conversation with both Department of Healthcare Finance and DHS around what the process is supposed to be, right? In terms of, we've had individuals who've testified before us who said, you know, they didn't get notified that their Medicaid was turned off until they went into a provider, very similar to the situation that you described. But they also say, but I turned in my paperwork on time. And so what is supposed to happen is if you submit the paperwork, regardless of whether or not your application is still pending, your benefits are not supposed to be turned off. I'm not sure if that was your situation or if DHS gave any more explanation.
No, what happened was in November the 30th, it was terminated. I called and got in contact with Rachel Pierre and Laura Zellinger. They immediately put someone on it in November, and I got a letter stating my Medicaid would go on without further notice, nothing for me to do. When I got COVID and went to CVS to get the Paxlovid on January the 1st of 2024, I was told that they terminated my Medicaid again. So I again reached out to Ms. Rachel Pierre, Ms. Laura Zellinger, who apologized profusely, got a case manager. She stayed on the phone with me for hours calling CVS and AmeriHealth Curatis. And they stated that it was a glitch in the system. And I said, this is the second time this glitch has happened. And I have chronic health conditions, as I stated in my testimony, which has been sent into you, SLE lupus, early stages of heart failure, and to stage 2 emphysema. And now I have COVID-19. I could not get the medication. CVS was trying to work with me and work with the DHS department, but I did recertify through District Direct. So the recertification was done. It's just there's not enough case management services to push all these applications and recertifications and paperwork through. And that really needs to be looked at. I'm looking for the DHS Peer Academy to come up, because us individuals with lived experience are very passionate about making this process a lot faster so people don't slip through the cracks, such as myself. Now, for me, I'm an advocate already who has access to a lot of the top directors of every agency. Well, what about the individuals behind me that don't, that this happens to?
Right. And that's our concern too, as well, right? In terms of the number of people who have come to testify to say, you know, either their clients submitted everything properly and the benefits were still turned off. One of the things that we have been trying to avoid is a situation whereby someone goes and they need something, right? They need their healthcare to work in a similar fashion. And then they get there and they're like, oh, it doesn't work anymore. So we're going to definitely follow up with the Department of Healthcare Finance about this, because what they're telling us the process should be, like when you submit your information on District Direct, your benefits are supposed to continue to be seamless regardless of the pending timeline. We're not seeing that play out in all of the cases. So I appreciate you being here, and of course for your continued advocacy across the board.
Thank you.
Ms. James, I thank you for being here. You know, we've had ongoing conversations with KIP around all the various suite of services that you all provide from the health standpoint. And as I told earlier witnesses, we're continuing to work with DC Health as well as Children's School Services to make sure that we're getting up to, you know, full coverage, which was what was promised, you know, in switching to this particular model. I do want to ask you about the AOM certification. The challenge that you raised around needing to go out to Silver Spring in order to do it. But I also wanted to ask you sort of a different question that kind of came up earlier with some witnesses from Amadon Bowen Elementary, which is, what do you all do around aftercare or sports? You know, technically the school health nurse is off duty at the end of the school day, but we know for either programs that have an extended day program or programs that have considerable after school programming, you have a bunch of kids who are still on your campus after.
Yeah.
And so what happens in those regards?
I'm just gonna say I'm new to KIP. I'm like 2 months in, but it looks like what's happening is there are some staff members who do work in after school programs with kids who are AOM certified, but I can't really say everyone who works with after school kids are AOM certified. I know recently we had one staff member who just got certified last week, and I think he's a sports coach for one of the schools, but yeah, we're lacking in that area.
Okay. All right. That's kind of what I figured might possibly
Yeah.
be the case. And so I, again, appreciate you being here. And I know I'm over my time. I just want to say for the record that we've been joined by Councilmember Matt Fruman. Councilmember Fruman, I have one other question and then we will get to you. Mr. Doyle, thank you so much for being here and for your continued advocacy, particularly around the workforce issues that we're having in the human services cluster. I wanted to ask you a different question, but I think that maybe you might have some insight on. I asked the folks from Food and Friends and the nutrition services side before, but are there particular nutrition dietary guidelines that service providers have to align for if you're dealing with a client who may be unhoused or housing insecure, but is also having other medical challenges that might require a specific dietary regimen?
I mean, I guess I'm not sure of a broad requirement. I mean, our role typically would be working with their medical provider on what that is and helping advocate for securing what they're needing based on different resources they're eligible for and how they can access that kind of specific food.
Okay. I'm over my time. Councilmember Fruman, thanks for joining us.
Thank you very much, Chairwoman Henderson. Just a couple of questions. So, Mr. Brenner, thank you very much for all of your work in this area. It is really important. I had chaired the board at the Lisner Home, so I've touched some of the issues that you are trying to deal with. I took from your testimony in some ways a good story in the sense that engagement with the Department of Health sounds like it's been very positive around the plan, positive around the regulations, and also the PR campaign that was launched sounds like something that that you felt like was a positive thing. Do you have a sense on the plan and the regulations? I know they haven't come out, but do you have a sense of where they stand and how far from the goal line we are? Because it sounds like a positive process, but just hasn't come to the kind of closure that one would like to see. Do you have a sense of where it's at?
Yeah, and I appreciate your support, and I don't disagree with your characterization there. What I know is in the pre-hearing responses, and thank you very much to Chairwoman Henderson and to her staff for including questions about Alzheimer's in the pre-hearing questions. And what they said in the pre-hearing responses from DC Health is that on the plan that they hope to be circulating a final plan in March. It's a longer story about implementing the training law. There are regulations, they still haven't been adopted or finalized. And they have to, the facilities have a choice. They can either do their own training or they can use DC Health provided training. And it's not going to be until September 30th of 2024, apparently, that DC Health will be able to have its own training. We're the Alzheimer's Association. We have incredible training resources for direct care workers, and we provided a couple of years ago after the law was passed, we were in touch with DC Health about that. So the short answer is, their pre-hearing responses say that the training law should be fully implemented in about 8 months from now, a lot longer than the people with Alzheimer's in DC like or would need. But certainly we have a positive relationship with DC Health. I haven't met Dr. Bennett yet, and I look forward to meeting her and working with her.
Okay, so thank you very much on that. And then on the PR campaign, it sounds like, a really positive PR campaign. I was very struck by your reference to the new medications that are out there that ironically make the importance of a PR campaign that much more important. Do you have a sense, is it that the funding was not adequate, that the funding carried the PR program for a certain period of time, and it would require more funding in order for the program to go for the full fiscal year?
I think that's what it was. And I will also say that in their pre-hearing responses, they say, DC Health says that they anticipate in 2024 renewing and extending the PR campaign. It only lasted from July to September. You know, it was great while it lasted. And I should add, DC Health has gotten a grant from the Center for Disease Control for Alzheimer's related activities in DC based on a strategic plan that they submitted to the CDC. So there's some funding from the CDC that I think probably can be used for public awareness. But right, there are 2 drugs that are approved by the FDA that are being given around the country. There's a 3rd drug, which hopefully will be approved in the very near future. But as I mentioned in the testimony, these drugs can only be given to people in a very early stage. So public awareness, increasing public awareness is now really very, very essential.
All right. Well, thank you very much and thank you for stressing that. That can make a real difference in people's lives and the lives of families. Mr. Richardson, you have cross-cutting experience in these areas, and one of the things that comes up is the need for direct care workers, and in lots of, for lots of different reasons. And I wonder, in your experience, is the challenge that we're confronting a challenge of pay, or is it a challenge of workforce development, or both? How do we get to where we have the direct care workers in place so that we can really fully serve people who need their support?
Thanks for asking that, Councilmember Fruman. It's clearly both from our perspective. There's a pay issue, but there's the infrastructure that creates the setting to create a pathway and a pipeline of workers to get into working for home health agencies, getting the education they needed. And if there's a breakdown anywhere in the system, whether it's the Board of Nursing or DC Health or Healthcare Finance or DACL, all of these agencies have a role to play in actually taking an individual, getting them trained and moving them into a job. And quite frankly, there's a lot of pressure. There's a lot of opportunities for people to take easier jobs, working at a retail store or walking a dog. We can make more money, than working in this really vital, important job. So I think it's a wage issue, but I also think the system supporting and recruiting and retaining people in this job sector is totally inadequate. And I think that until we bring in all the different district agencies that have a role in creating the infrastructure to move people into these jobs, to take care of our vulnerable residents, until we fix the system, we're going to have a problem moving people into those jobs and taking care of things. And we see in the coalition breakdowns all across district government in the way that we set people up to get trained or to get cared by these folks. I just lost you.
I said thank you. I muted myself because there were sirens going by while you were talking, but and then forgot to unmute myself. But thank you very much for your work in this area. Thank you very much to all of the witnesses for their testimony. I'm well over my time, so I'll step back now, but thank you.
Thank you, Councilmember Fruman. And thank you to this panel of witnesses. We're going to go on to our next and final panel. Patricia Quinn, Kirk Gallagher, Liz, it says Michaela Deming, but it will be Liz Andongo, Ann Thiel, Felix Hernandez, Cynthia Martin, Lisa Fontaine, and Lisa Case. Give it a minute as we adjust. Okay, I see Patricia. Why don't you go ahead and get started?
Thank you, Councilmember Henderson, for the opportunity to share testimony at this oversight hearing for DC Health. I'm Patricia Quinn, Vice President of Policy and Partnerships at the DC Primary Care Association. DCPCA has multiple meaningful partnerships with DC Health across several DOH administrations and bureaus, including the Community Health Administration, HEPRA, and more. Some examples are a robust cancer navigation program, support for health center emergency preparedness, and several maternal infant health initiatives. In that regard, thank you again for hosting a briefing of our young parent well-being survey data and young parent panel. I'm working with staff at DC Health to present to the DC Health team in the near future. And although DCPCA's testimony does not explicitly discuss food security, our data shows the close connection between healthy food access and young families' ability to thrive, and we support our colleagues doing that work. I'll concentrate today's testimony on our shared focus with DC Health on developing and sustaining robust primary care. A recent Washington Post article on the health of the district's Black residents indicates they were almost 3 times as likely to die in DC as white residents in 2022. And that gap has grown steadily since the 1960s. The road to health equity runs through a primary care system that ensures that every patient and provider benefits from a lifetime of human caring and connection. Yet the sector has suffered from chronic underinvestment. With the right policy framework in place, no organizations are better positioned to provide effective primary care than our member community health centers. DC Health is an important voice and thought partner for DCPCA and for sister health sector agencies in championing exactly the kind of preventive services primary care is designed to deliver. New payment models and care delivery methods being explored by the Center for Medicare and Medicaid Services center primary care as the quarterback of an improving health system. DC Health leads the district's cross-sector work to identify workforce needs and devise strategies to address existing and emerging gaps. DCPCA urges continued mining of the recommendations from the Mayor's Healthcare Workforce Task Force. District focus on apprenticeships, internships, and career pathways can make a meaningful difference in the capacity and quality of our health system. The primary care office at DC Health supports a range of primary care workforce initiatives that are important tools for a primary care system confronting significant challenges in finding and retaining staff. The DC Health Office of Health Equity is a most valued partner to DCPCA in meeting our mission to advance racial and health equity. DC Health's groundbreaking health equity report set the stage for health system action to address health-related social needs and structural drivers of health. OHE's work led to increased recognition of the significant role of social inequity in creating inequitable health outcomes and led to consideration of policies that leverage healthcare dollars to meet social need. A key workforce area with potential for significant impact on addressing social drivers of health is the community health worker role. As the Center for Medicare and Medicaid Services and our Department of Healthcare Finance adopt policies to enhance the role of connectors in the health system, we will look to DC Health, excuse me, to establish competency-based certifications endorsed by the field. Central to DCPCA's efforts to achieve racial and health equity is our work to establish patient-reported well-being measures. Again, the Office of Health Equity is a key thought partner in how we might utilize a well-being measure to hold health system payers and providers and other cross-sector investors accountable for improvements in individual and community well-being. We look forward to opportunities for collaboration on well-being in the year ahead. Thank you again for the opportunity.
Thank you. Mr. Gallagher?
Good afternoon, Chairperson Henderson and members of the council. Thank you for the opportunity to testify today at this oversight hearing. My name is Kurt Gallagher. I currently serve as Executive Director of the DC Dental Society, which represents approximately 400 dentists practicing here in Washington, DC. I want to provide an update on our experience working with DC Health and the Board of Dentistry. I am pleased to report that through the most recent licensure renewal period, which ended officially on December 31st of last year, that it appears that there have been improvements in terms of processing of dental applications. Looking at the number of licensed and registered dental professionals in 2024, compared to 2 years ago, January 2022, there's a notable uptick. But I also want to draw attention to areas where there are opportunities for continued improvement. Some of these areas I've addressed in previous comments, and there'll be a new one I want to raise at the end. First of all, expanding the scope of practice for dental assistants. This has been under development and in the regulatory approval process for several months. The members in the dental community are very anxious to have these regulations finalized. They will expand the scope of practice for dental assistants by creating a new level 3 dental assistant, which should enable dentists to provide enhanced care and expand the capability to serve the community. Related to this, though, we continue to call for a repeal of the requirement that all dental assistants register with the Board of Dentistry. DC is really out of alignment with our neighbors and a lot of other states that require every single dental assistant to register. We ask that this committee consider updating the HORA and updating the requirements for registration for level 1 dental assistants. They provide the basic level of assistance in a dental practice. And these positions are really a pathway to the middle class. They are an entryway to the dental profession, and the fees, in fact, that staff have to pay to register also create a barrier. $190 registration fee plus the $50 criminal background check fee. All those are barriers to increasing our dental workforce here in DC. I'd also like to reiterate our call that the dentist scope of practice be expanded to allow not only the administration of botulinum toxin or Botox for dental purposes, but also for cosmetic purposes. This is actually part of legislation that was introduced late last year, B250632, the Dental Specialties Licensure and Scope of Practice Amendments Act. I hope that this legislation will be updated to allow for this expanded scope of practice. Finally, I know it's not the purview of this committee, but I want to get to perhaps one of the most important topics affecting the dental community, a lot of our providers this year, and that is taking a look at the Medicaid fees that are used to cover dental procedures. Those fees have actually been reduced since an adult dental benefit was established back in 2007. I realize that that's under the purview of healthcare finance, but I do want to draw attention to this issue of the committee. I'll follow up with more substantive comments, and there are a couple of other areas I want to address in the comments that we've addressed in previous statements. Thank you for your time, and I'm happy to answer any questions that you may have.
Thank you. Liz?
Good afternoon. My name is Liz Odongo, and I'm the Director of Grants and Programs at the DC Coalition Against Domestic Violence. We are the federally recognized statewide coalition of domestic violence service providers in the District of Columbia, representing 18 member programs working with survivors across all 8 wards. 39% of women and 25.5% of men living in DC have experienced sexual violence, physical violence, stalking, or a combination thereof perpetrated by an intimate partner. These rates are higher than the national averages. About 10% of DC's homicides are domestic violence related, with most of those involving guns. Teen girls are experiencing record high levels of violence. 70% of youth who have dated within the past year reported experiencing domestic violence. 88% of them experience school interference from a dating partner. Stronger cross-collaboration among school staff and domestic violence advocates to address dating and sexual violence is necessary to ensure students are safer while in school and with their peers. We have a small amount of CDC rape prevention and education funding through the DC Health, which allows us to support the Expect Respect curriculum. That program focuses on educating high school students about safety, social support, and skills for healthy relationship building. More funding and more coordination with DCPS is needed to reach more youth. DC Health has been an important commitment by recognizing domestic and dating violence as a public health issue and has been a great partner to us. We've been asked to develop training for their DC MAP team to help young mothers navigate infancy and newborn care and wellness. I must note here that women in the U.S. are more likely to be murdered during pregnancy or soon after childbirth than to die from the leading obstetric causes of maternal mortality, and that Black women are at substantially higher rates of being killed by partners around pregnancy. This training partnership would help staff recognize domestic violence in a culturally competent way and offer trauma-informed support to hotline callers. The work has yet to be funded. It would only cost around $25,000. This DC MAP program training is a good example of the type of work we could be doing with DC Health with just a small amount of dedicated funding. With adequate funding, we can develop training across all government agencies, starting with DC Health, to give government staff the support they need to prevent domestic violence in the district. There is no local DC funding for domestic violence prevention. With dedicated funding, we will be able to address the rise in dating and domestic violence in the district through expanded prevention education and building interagency capacity to address domestic violence. We are DC's leader in efforts to prevent dating and domestic violence. We invite all district leaders to join us in this life-saving work. Thank you, Chairperson Henderson, for the opportunity to testify today, and I'm happy to answer any questions you may have.
Thank you, Liz. Anne? Anne, you're on mute.
Somebody had to do it, right? I apologize. My name is Anne Thiel. I have been a volunteer at the Humane Rescue Alliance for 7 years now, and I appreciate the opportunity to serve as a public witness at this oversight hearing. My volunteer services at HIA primarily consist of supporting the animal care staff at the Oglethorpe location by taking out shelter dogs, and I also serve as a foster for HIA. I go to the Oglethorpe location about 5 times a week. I wanted to take this opportunity and share a little bit about how I've experienced this last year at the shelter, particularly in the areas where I volunteer. Overall, what I have seen is a team that has been hardworking, diligent, and resilient in the face of unprecedented challenges. This has been a very difficult year for animal shelters around the country. All over the nation, shelter animal intake has been up, lengths of stay extended, and adoption numbers have been down. For HIA, I can also say that we have seen fewer volunteers return to the shelter after the global pandemic restrictions were lifted, and so animal care staff had far less support than before. At the same time, the DMV area has had to contend with a very difficult strain of canine influenza that also infected many of our shelter dogs. So while shelters were dealing with increased influx of animals and saw fewer animals leave, they also had to face a considerable additional challenge. At short notice, PPE had to be ordered, cleaning and other protocols had to be developed, etc. Was it always perfect? No, but I think it was the best the team could do at any given point of time, considering the resources and the circumstances. What happened was that housing situation for dogs at the shelter was challenging as temporary shelters had to be provided. Larger temporary shelters were ordered soon after the flu developed, but it took a little bit of time for them to arrive and be set up. So there was a little bit of a gap in providing appropriate housing. I do know that special efforts were made to transport dogs to other shelters. Special calls for fosters were sent out as soon as the flu was sufficiently contained, and also special adoption campaigns were offered, like fees were waived. New programs were implemented to help community members care for their pets in their homes so that they didn't have to come to the shelter, etc. I can only reiterate that we currently have some of the most caring, hardworking, and diligent animal care and foster teams that I've ever worked with in my time at HIA. They're doing the best that they can given the circumstances and challenges that they have been facing, which has been extraordinarily difficult. Happy to answer any questions you may have.
Thank you. Felix?
Good afternoon, committee and council member. My name is Felix Hernandez, and I'm an advocate for the Family Support and Home Visiting Department at Mary Center. A home visiting council member and co-chair of the advocacy subcommittee. Unfortunately, home visitors and participants were not able to show up to testify with me today, as they did not have the capacity to prepare for this hearing with just 1 week notice. So instead of hearing from them directly, I'll try and share what I can from what has been shared with me. My testimony will focus on the lack of transparency regarding DC Health funded home visiting programs in the district that make it difficult to address ongoing hiring challenges, to which itself is an issue exacerbated by the city's weak investments into social support programs that benefit parents of young children like home visiting and similar programs. In 2023, HRSA granted over $1.8 $8 million to the District of Columbia and for the McVie programs. However, McVie home visiting programs themselves only received $1.1 million. There's a lack of transparency about how the remainder of the funding is spent to support maternal and child outcomes through home visiting, and urge the committee to establish better means of tracking and reporting on these investments. This testimony is also a general call to action for DC Health and its committees to maximize and leverage the full power that federal McVie investments can have to support home visiting programs in DC. From what I see, DC Health is not making the most of these federal funds, is not well coordinated within and with others to maximize of program.
Mr. Hernandez, your camera
And
is.
others who support parents.
Mr. Hernandez.
Often, this creates burdens on programs that detract from time necessary to support program participants parenting young children. Yes, I'm sorry. I have stopped my camera in the hopes that you can hear me better now.
Yes, we can hear.
Hello?
Yes, we can hear you better now.
Hello?
Can you hear us?
Hello, can you hear me? Great. Apologies for that. Yes, I can hear you.
Okay, great.
Okay, I'll resume.
Mm-hmm.
I'll add that according to Alliance for Early Success, nationally, just over 2% of families with infants and toddlers who could benefit from evidence-based home visiting services are receiving them. We have yet to reach our peak in terms of connecting with all eligible and willing participants in DC. We need strong, expansive, braided funding to make sure that you can contribute to a version of DC where all infants and young children equal access to programming that supports them and their families. Programs can be a win-win scenario for all of our teams. I will also remind this committee that for every $1 invested in home visiting services, the city can save about $2 to $6 in other costs across the city. This is a sound investment and can only have this impact when programs are fully funded with thriving wages for a stable workforce. I'll share a quick example. If a grant expects for a program that I have learned from, if the grant expects a program to support a total of 200 moms and dads in the district a year, that means that 4 home visitors are tasked with supporting a minimum of 25 families. If wages do not attract and retain a home visitor long enough to develop a strong practice, participants are ultimately the ones negatively impacted by this trend. A thriving wage should cover 30% of their income. Often these grants can't even cover the full workforce necessary for the program to run, and institutions have to go into I forget the term for it, private funding resources. If these grants set the expectation to a team of 5 to work on transforming outcomes for the better outcomes for parents, but the grants cannot offer these home visitors a wage that can meet their needs, the grants are not setting up these programs up for success. DC Health should coordinate among their peers with grant portfolios that set up home visiting and similar programs to see how the city improves recruitment and retention, as well as access to these programs for participants. There is an opportunity here for DC Health to draw down more McVie dollars to support home visiting programs in DC, given that in 2024, McVie funding resources have been increased. Programs need to see processes that impact the funds allocated to home visiting and similar programs receiving these grants. I hope and trust and will rely on the council to city administrators and programs to work together and commit to finding solutions so that we can plan and so that we can see the changes we want to see. We will also plan to follow up on last year's compensation workforce brief this spring, and look forward to be able to continue these conversations with you and welcome any questions you may have. Thank you.
Thank you. Cynthia Martin?
Yes, can you hear me?
Yes.
Okay. Hi, good afternoon. My name is Cindy Martin. I began volunteering for the Washington Humane Society in 1994, 30 years ago. Over the years, I have spent thousands of hours serving many roles, fostering 150 cats and kittens, doing meet and greets for adoption events, vaccine clinics, walking dogs, including those under humane law enforcement, and cleaning kennels. This past year has been one of the most stressful. Adoptions are down throughout the country, and surrenders and strays are up. During a 2-week period last summer, the dog population basically doubled. At the same time, there was a flu outbreak, which was throughout the country. We were unable to transport dogs to other shelters or to send them to foster homes with other animals. Interaction with the public was quite limited, and adoption events were on pause. For a short period of time, dogs were crated until larger pens were obtained. Extra contract staff was hired. Staff and volunteers had to don personal protective equipment, which was very cumbersome and required twice as much time to get half as much done. A lot of the volunteers stopped coming in because they were afraid to spread disease in their homes or because it was so hot and uncomfortable. I am aware of a letter and news article sent by a small group of volunteers, some of whom were new volunteers or who had not volunteered in a long time. I have never been approached by anyone who signed the letter, nor have many other very active and long-term volunteers. Today is the first time I've ever heard of the HRA Volunteer Action Group. It is also my understanding that the behaviors of some volunteers made the staff feel unsafe. Some of the recommendations made by these volunteers are already in place, and others were unreasonable from my viewpoint. There are a number of recent posts on social media that euthanasia decisions are being made for lack of space or for minor incidents. There is a process for this decision that requires 2 people to review and sign off. There is a scale to measure bites for severity. It would be highly unethical to adopt out a dog who is aggressive to people. While heartbreaking, these dogs were not adoption candidates. I am familiar with many of the incidents. Sadly, some dogs do deteriorate in the shelter environment. HRA is doing everything possible to increase adoptions and fostering and to provide resources to enable people to keep their pets. I am proud to be an HRA volunteer and will continue to support the hardest working group of people I've ever seen. Thank you for the opportunity to speak.
Thank you. Ms. LaFontaine?
Hi there. Thank you for the opportunity. I appreciate it. We had a good meeting with Dr. Bennett and her team last.
Lisa, are you still with us? Lisa? Oh, okay. I think she's going to come back. So why don't we go to Lisa Kays?
Hi.
Hi.
Okay. Thank you for the opportunity to offer feedback at this oversight hearing for the Department of Health. My name is Lisa Kays, and I've been a licensed social worker in Washington, D.C. since 2011. I am currently in private practice in DuPont Circle, where I treat adults and supervise social workers as they work towards their independent clinical license. I would like to address in particular the disappointing response of both the Department of Health and the Board of Social Work to data revealing that the ASWB's social work licensing exams, by the ASWB's own admission, are biased on the basis of race, age, and English-speaking status. We also know through our advocacy and outreach, they are also biased and highly challenging for DC's deaf social workers. DC would have more than 450 additional social workers today if every demographic passed at the same rate as young white social workers. Given the social work shortage in DC, the Social Work Licensure Modernization Act of 2023 was designed to address this barrier. I am confused by the DOH and BOSW's response to this legislation. I don't understand how they could hear the overwhelming testimony in support of the act, which was broad, diverse, and grounded in fact, decades of academic research, history, and personal testimony of direct harm the exam has done to DC social workers, and yet still oppose this common sense legislation. Oddly, the reasons the DOH and BOSW have given for rejecting the legislation are grounded only in the ASWB's PR talking points, which purport that the exam's importance is in measuring baseline competence and public protection. However, even an iota of due diligence into this issue will demonstrate clearly that there is not one piece of evidence that these tests are correlated with competent social work nor public protection. It makes sense to me that the ASWB would tout this falsified party line because they profit from it to the tune of millions of dollars a year. What I don't understand is why the DOH and BOSW would do so, as hopefully their interests are aligned with the citizens of the District of Columbia and not the ASWB. When the legislation was proposed by Councilperson White, I was impressed and hopeful that DC would be a leader in remedying this biased barrier to licensure and bastion of systemic racism, which is a blight on the social work profession. My hope turned to frustration, though, when DOH and the BOSW turned to a thoughts and prayers response, claiming concern over this bias and the harm it does, while doing nothing to tangibly address it, when they have the most power to do so of any DC government entity. Given the overwhelming evidence presented in testimony and the united front of the impacted social work community, I am requesting that the DC Council support and pass the Social Work License Modernization Amendment Act of 2023, despite the DOH and BOSW's objections. Despite these unfounded objections, you can proceed with the full confidence that what you are doing does not compromise quality of services while being grounded in social justice, economic justice, and racial equity principles. I thank you for your time, and I'm happy to answer questions.
Thank you. Okay, I think we've been rejoined by Lisa LaFontaine.
Yes. I am back. Can you hear me?
Yes.
Great. Thank you for this opportunity. I'm really grateful. I'm the president and CEO of the Humane Rescue Alliance. I want to start by saying that we had a really good meeting with Dr. Bennett and her team last month, and she had shared with us that DC Health had received some allegations about our performance of the contract. I know that DC Health did about 4 unannounced visits to our facilities in the late summer and in the fall, and they also worked closely with us through this devastating canine influenza outbreak. We're really grateful that they came in to do an objective assessment of our operations, and we were pleased but not surprised to hear that they had found the allegations unsubstantiated. There's been a lot of passion in the testimonies today. DC residents love their pets, and over 90% of them consider them to be fully fledged family members. And yet, more and more people are struggling to care for them. Our phones are busy and our lobbies are full of heartbroken pet owners who are grappling with this burden. This is a crisis, and it's not just here, but it's across the country. Economic pressures, housing instability, and a host of social stressors are making it harder for people to provide basic pet care. Every hour of every day, we see residents who can't access or afford vet care. And just this year, the only vet east of the river closed her doors, meaning that about 70 to 75,000 pets in wards 7 and 8 have no health care or no services. Immediately, we began to provide spay and neuter service in both those wards. Our team brought the pets from the homes into our Oglethorpe Street clinic and returned them home that evening after spay neuter to recover with their families. When pet owners can't access vet care, there is suffering. Owners feel like a failure. Animals get worse from treatable conditions. Communities see disease outbreaks. Families break apart, and the fabric of our community is torn. Our vision and what we think is the best way for us to serve this community is to build stronger safety net and care systems for pet owners. And so last year, we provided 23,000 free pet meals and other supplies. We helped 9,016 animals through low-cost vaccine clinics, which creates a really critical bulwark of disease prevention. And through our Treat to Return program, which is essentially a day clinic, we were able to keep 192 pets in their homes by giving them free vet care. Last March, we launched the nation's first field veterinary program, which is a mobile clinic that provides in-home vet care for those who can't afford a vet or who can't physically get to an appointment. We have now treated 1,111 pets who otherwise would have come into our shelter system. And now we're getting ready to open a pet health center just a few hundred feet from the former vet clinic in Ward 8. Our goal is to truly be part of the community east of the river rather than simply providing services. We intend to scale all of these initiatives. If we can intervene early, before people face pet relinquishment and before pets have to suffer needlessly, we will build a happier and healthier community. My colleagues across the country are struggling to figure out what to do in the face of rising animal intake and dramatically decreased adoptions. The best way to ease the burden on the shelter system is to keep more animals in their homes with the people that already love them. The best shelter is really a humane community, and that's what we're trying to build here in DC. We're focused on programs and services that remove barriers that are hurting people's ability to care for their pets. That's what our community is asking of us, and it's what they deserve. Thank you.
Thank you. And thank you to this panel of witnesses. That is the end of my list. A couple of things. So, Mr. Gallagher, first, thank you so much for being here. It's always good to hear that you feel like the renewal process went better this time around. Have you had any of your members who have raised concerns and or alarms around the processing times? Because when we look at the data provided to us from DC Health about the average processing time, it did go up this past fiscal year.
Interesting. That's surprising. It seemed that this year that we had far fewer requests for assistance. And then when they did come through, we saw that it was typically within a day to a day and a half that the member received their license. There are a few exceptions to that. And also, again, looking at the numbers, there are about 1,300 dentists licensed as of today or as of yesterday at the Board of Dentistry meeting versus about 988. So it'd be interesting to see those data, though. I think the real test is how the board handles new license applications. That's where there appears to be the real problem. The DC licensing health portal seems to help a lot with processing renewals quickly, but it's the response to the new licenses where the system really has trouble.
Okay, that's helpful for us to know. And I mean, it could also be that, you know, the Board of Dentistry is a bit more streamlined than some of the other boards who might be having some difficulty in terms of getting through the process. So nonetheless, thank you so much for being here. Ms. Quinn, thank you so much for being here and for the continued partnership with the DC Primary Care Association. I know that there will be some other things that come up with some of the other agencies. We'll be talking more with you on some pieces. Ms. Ondongo, can you please provide your testimony? I think you had a lot of good information and we're trying to scribble as fast as we can, but if we have your written testimony, we could definitely follow up on some of those things. Ms. Kays, you know, that bill is still pending before the committee, and we are in conversations to try to figure out how best we can move forward. So just so you know, we haven't forgotten. It's not over. We're still working through some of the conflicting issues.
Okay. Thank you.
Yep. Thank you. Mr. Hernandez, thank you so much for your testimony as well. We heard from some other folks earlier today about home visiting programs. And so, you know, we'll continue to move on that. As you know, we did pass the legislation for home visiting to be Medicaid eligible. So that is already progressing through the process. Okay. Now to HRA. Hi, Ms. LaFontaine. I don't want this to sort of seem like a oversight hearing for HRA, but obviously if you've been listening throughout the day, we've had quite a few people who have testified particularly about the services there. And I'm also trying to be mindful of my time because Councilmember Fruman is also still here as well. So let me first start. There seems to be some confusion about the spay and neuter clinics that are included within the contract or not. And so I wanted to ask you if you could provide some clarification in terms of, you know, what the requirements are.
Yeah, the spay neuter services are private HRA services funded by our donors. They aren't part of the contract. I'm not sure why that confusion exists. So it's completely outside of separate from contract activities. And I think DC Health would corroborate that as well. But I do think it's important to note that we take in last year 10,140 animals, and we do spay and neuter all of the animals who come through our doors. We also do targeted spay neuter, like what I talked about earlier, where we're going into wards 7 and 8, where there's no vets, literally picking the animals up at their home and bringing them back to us. And I don't disagree with the things that people are saying. We would love to be able to do everything for people and animals that we possibly could, but our resources are finite, and probably the most finite and hard to acquire resources are our talented veterinary surgeons and support teams.
Right.
And we do not see people having to give up their animals because of a lack of sterilization, but every hour of every day we see them having to give them up for a lack of health care. So what we've done is prioritize providing healthcare services that keep people with their pets.
Can I follow up on that?
Yeah, sure.
So you confirmed, and obviously we've had conversations about this in terms of the clinic that you guys are opening in Southeast. Do you all have a timeline of that opening?
Yeah, we took possession of the building on January 1st. We're in there now painting it, fixing it up, and we're going to be opening it a soft launch on February 1st.
Okay. All right. So making progress there.
Yeah, making progress. Yeah.
And I'm over my time, but I'm going to keep going. If Councilmember Furman, he'll pop up. He'll pop up. One of the witnesses who testified earlier sort of presented some, I thought, troubling testimony around some of the dangerous pending litigation dogs.
Yeah.
And are we able to acquire the appropriate protective gear so that those dogs can be exercised?
So there are dangerous dogs that we house for the district are probably it's just one of the most difficult, painful situations we have, because usually by the time they're being quarantined with us, they have regressed in a significant way, so they can't be quarantined in their homes. And depending on the level of aggression, our protocols either allow us to do restricted walks or no walks at all. And I think that the person who testified was probably talking about Lightning, who's been with us since May and has been so unpredictably aggressive that we've been unable to walk him. And so our protocol in those cases is that the behavior team does in-kennel enrichment. They do click and treat. They have busy boxes. They have other stimulations to give them. Nothing replaces walks, but the types of equipment that are being talked about, I'll talk more with our officers about it, but I don't think that they would work in a case like Lightning's. Likely that type of equipment is going to provoke whatever fears and aggression that he already has. It's going to, the equipment is not made for that. It's made for training of police dogs. This is a really different circumstance.
Okay. So, what happens in those situations where you have a dog too dangerous to walk? What's the end solution here?
Well, so the way that it works, we have animal control investigators as part of the contract, and they look into any case where a dog has bitten and injured either a person or another animal. And then if it is a dangerous dog and has bitten multiple times, we will make a recommendation to DC Health as to whether or not the dog should be declared dangerous, potentially dangerous, or returned to their owner. And I believe that in Lightning's case, we have recommended that he is a dangerous dog. We have heard from the team at DC Health recently that they think they're going to have a decision in a week or so. What I would advocate for is a shorter investigation time of our dangerous dog recommendations so that decisions are made more quickly.
Yeah, because you said if this dog has been with you since May, it's now almost to the end of January. That's a long time. That's a very, very long time. Okay, I'm going to stop here because I am 3 minutes over. Councilmember Fruman, do you have any questions for this panel?
Thank you very much, Chairwoman Henderson. No, I don't. I want to thank the panel for their testimony. I don't have questions, but thank you very much.
Okay, thank you, Councilmember. Thank you, Councilmember Fruman. Ms. Fontano, I do want to ask another question around vaccines.
Mm-hmm.
Is this a similar situation to the spay and neuter where it's outside of the scope of the contract, or is this something you're all supposed to be providing?
So vaccine clinics, we're required to provide 10 hours a week of vaccine clinics at our facility. And I think this could be an example of where if we rewrite the contract, we could do it in a more precise way. What happened this year is because we had an outbreak of canine influenza that lasted from officially late July when we got the first positive test to December 18th when we had the last case. It wasn't safe for us to be bringing owned pets into the facility to do vaccines when their animal could be exposed to a really pernicious form of influenza. So rather than having them in-house, what we did in collaboration with our partners at DC Health is have more vaccine clinics out in the community, and those have wildly exceeded 10 hours a week. So it's just a matter of where we've been doing them.
Okay, so you're saying you have done the vaccine clinics just at different locations outside of the 2 shelter buildings.
That's right. We've done thousands of vaccines this year. I think it was, let me just look.
Lisa, right? We've had regular, and so especially over the next few weeks, along with DC Health. But I don't have any further questions for this panel of witnesses. So I want to thank everyone for testifying. If you wanted to testify but weren't able to do so, hold on, let me find my notes here. Okay. If you wanted to testify for DC Health, but weren't able to do so, you could submit written testimony for the record, and we'll accept it until February 1st at 5 o'clock. You can submit your written testimony on the council's hearing management system website. So dccouncil.gov/hearings. I want to thank everyone who presented testimony, answer questions today. Your insights and expertise will be immensely helpful as we prepare for our conversation with Director Bennett and her team from DC Health. So we'll reconvene this hearing on Monday, January 22nd at 9:30 a.m. Again, for everyone, if you're looking for the pre-hearing questions, those are also available on the DC Council website as well. The time is now 1:43 p.m. and this hearing is recessed until Monday, January 22nd at 9:30 a.m. Thank you.